Hello. Yes, hi. Yes, hi, this is Freddie. Okay, so welcome everyone to the 35th lecture of Dr. Haider Step 1. Um, Thank you so much for waiting for everyone to join. Uh, can you guys hear my voice? Okay, perfect. Okay, perfect. So, welcome to the 35th lecture of Dr. Haider Step 1. So far, we are done with a lot of high yield topics from First Aid 2020. Okay, we have mastered CVS, endocrine, GI, neurology, psychiatry, and we are going to rush through renal. Okay, because renal is pretty hard. It's comparatively pretty easy to understand, and okay, we will not rush through renal. Okay, obviously we will take our time, and we will make sure that each and every student understands every high yield concept from the renal system. Okay, but having said that, we will go through our regular 10 pages, and we will try our best to make sure that we stick to the 10 pages of first aid. Having said that, have you guys done the UWorld questions associated with psychiatry? Did you guys do the UWorld questions associated to psychiatry? Okay, how many questions did you guys do from the UWorld associated to psychiatry? 30 questions, 20 questions. Okay, that's very good to know. So, did you guys come across questions regarding the ego defense mechanisms? I'm sure you must have had. Okay, when you did you answer with confidence? Did you have any wrong answers? That is very good to know. Okay, congratulations. That's very good. Okay, so are you guys confident with psychiatry? Okay, and was our lecture helpful regarding regarding the knowledge of psychiatry? Okay. Okay, that's very good to know. Do we have any new students over here who have not received all the lectures of this week? Do we have any student over here who have not received the lectures of this week? That is lecture 31 to 35. Okay, Dr. Mohammed, which lecture did you not receive? 31 and 32. Okay, perfect. We are going to send it to you right away so that you don't so that you have not missed out on any lecture for this week, because we believe that you have your transactions cleared, and you should be getting all the lectures for this week, because starting new week we will have our new chapters and requests for new transactions. Okay, and the UL questions. Okay, good. The UL questions, the UL notes of the questions are in the Facebook discussion group. Okay, it's in the Facebook discussion group. Okay, so if I'm pretty sure you were added in the Facebook discussion group, you can find all the UL notes over there. Okay, so if you can go to the Facebook discussion group, you will see that we have months long of UL notes in our home feed, and please use those notes to copy paste and make it into a proper storage, Microsoft Word and note copy for your URL notes. Okay, and we will be making sure to provide you the lecture 31 and lecture 32. Okay, coming next week, we will be starting with lecture 36. And from today, we will be beginning with the renal system. Okay, good. Before we begin, should we do a quick review and recapitulation of our previous topic regarding psychiatric pharmacology? Everyone? Okay. Okay, good. So we will go through them very fast because these are comparatively pretty easy. Okay. So if everyone is ready, then we are going to begin our review and recapitulation section of the lecture regarding the psychiatric pharmacology. Okay. So is everyone ready? Should we begin? Okay, good. Okay. So we will start with psychotherapy. Okay. And so what is the name of this psychotherapy where the stressing point, the stressors are identified so that the person can stay away from the stressor and avoid alcohol? Very good. What is the name of this therapy where you have to have good conversation and communication skills in order to get through to the person so that he or she understands what problem they have? Very good. Dialectical behavioral therapy. Okay, very good. What is the name of this therapy where two people who are going through the same problem can have interpersonal relationships and communication skills? Interpersonal therapy. Very good. What is the name of the therapy where a person uses empathy to understand what the patient is going through? In supportive therapy. Very good. Okay. Okay. Can you name some highly potent can you name some highly potent can you name some highly potent typical antipsychotic? Haloperidol. What was the mnemonic that we used? What was the mnemonic that we used to remember the high potency antipsychotics? Hal tries to fly high. Very good. Haloperidol. Trifluoperazine, flufenazine. Very good. How about the low potency typical antipsychotics? Low potency. Very good. So we have one that is chlorpromazine and thioridazone. Okay. Does everyone remember the mnemonic that we used to remember the low potency typical antipsychotic? What was the mnemonic that we used to remember the low potency antipsychotics? Very good. Cheating thieves are low. Okay, good. Okay. Can you guys name me the broad categories of the adverse effects that we can see in a typical in a patient undergoing treatment with typical antipsychotic? QT prolongation, sedation, orthostatic hypertension, extrapyramidal symptom, antimuscarinic, antihistaminic. Okay, very good. How about the ophthalmologic adverse effects that we see in the patient? Ophthalmologic adverse effects that we see in the patient. Corneal deposits by chlorpromazine, very good. And thioridazone has retinal deposits. Very good. Okay. Let's talk a little bit about the extrapyramidal sign symptoms of the typical antipsychotic. If the patient comes with an extrapyramidal sign symptoms in the first hours to days, what extrapyramidal sign is the patient going to show? Acute dystonia. How about days to months? Akathisia and Parkinsonism. Very good. How about months to years? Tardive dyskinesia. Very good. Okay. Tardive dyskinesia. Okay. Okay. If a patient is being treated with atypical antipsychotic and there has been a treatment failure by the atypical antipsychotic, and which drug are we going to use for treatment resistant schizophrenia? Clozapine. If we use clozapine, What should we do in order to monitor that the clozapine is not having any adverse effect? White blood cell count. Very good, because they can cause agranulocytosis. Okay. Okay. If a person is on lithium, which serum test should we be doing again and again to make sure that there has been no toxicity regarding lithium? Thyroid test. Very good. Serum TSH, T3, T4. Okay. What is the name of the drug which stimulates 5-HT1A receptor, and we can use that drug for generalized anxiety disorder? If we get anxious, buspirone. Very good. Okay, buspirone. Very good. Okay. What are the drugs that we can use in atypical depression? Metrazepine. Okay. Okay. Good. Okay. What is the mechanism of action of tricyclic antidepressant? What is the mechanism of action of tricyclic antidepressant? Inhibits 5-hydroxytryptamine and norepinephrine reuptake. Okay, very good. Okay, next one. Next one is, how long do we have to wait before we begin treatment with SSRI after the treatment? No. Okay. So basically, my question was, how long do we have to wait? First of all, for everyone who has said 4 to 8 weeks, okay. First of all, again, how long do we have to wait before we begin SSRI in a patient with a history of being treated with monoamine oxidase inhibitors? 2 weeks minimum. Okay. 2 weeks is needed for the enzymes to regenerate and for the drug to really to get released from the body. Okay, good. If a person is diagnosed with major depressive disorder, and the person has been started on SSRI, and at the end of 2 weeks, the person comes and tells you, the patient comes and tells you that the drug is not working. How long do you think you have to ask the patient to keep on having the drug in order for the drug to work? 4 to 8 weeks. Okay, good. Okay, next one. Next one is, um, can anyone tell me if they remember the picture mnemonic for atypical antidepressants? Only yes or no. Do you guys remember the picture mnemonic for the atypical antidepressant? Okay. So we're going to walk through that image. What was the first thing that we drew in that picture? Villa. Villa 4. Villa 4. We will go one by one. We will go one by one. Villa 4. Villa Zedon. Okay. What was the second thing that we drew in that picture? Vortex. Vortex 4. Vortioxetine. Okay. What was the thing that we drew in that picture? Cycle. Cycle 4. Cycle 4. Varenicylene. Very good. Okay. And who were the three characters on the cycle? Okay, good. So trazodone, metrazepine, and bupropion. Okay. Out of all of this, which drug is an alpha 2 antagonist? Metrazepine. Okay. Which drug is responsible for causing priapism? Okay. Which drug is responsible for helping out with nicotine cravings. Okay. Okay. If a person is on SSRI and the person has an unfavorable sexual side effect profile, which drug should we use? Bupropion. Very good. Bupropion, not buspirone, bupropion. Okay. Okay. If a person has if a person has atypical depression, which atypical antidepressant can we use? Metrazepine. Okay. What is the long-acting opioid that we can use in order to help out with heroin detoxification? Methadone. What is the name of the partial antagonist that we can use? That's no problem, Dr. Uday. No need to apologize. Okay. Buprenorphine. Very good. What is the short-acting opioid that we can use in order to prevent acute opioid overdose? Naloxone. Okay. Which one is the long-acting one? Of course, if it's not naloxone, it's naltrexone. Okay. So naltrexone is long-acting. Naloxone is short-acting. Okay. Absolutely wonderful. Thank you and congratulations. Thank you for putting your attention and congratulations for mastering all the important drugs of psychiatric pharmacology. Okay. You guys are doing absolutely amazing. I'm not sure how much we are helping you guys out regarding the lectures, but from what it seems like that you guys already knew this from before, which has made these things extremely easy for us to discuss and extremely easy for you to understand. Having said that, if anyone has any issues, do we have any? Do we have? Do we have S. Hussein, Dr. S. Hussein over here? Dr. S. Hussein, who has sent us an email regarding pharmacology. Do we have Dr. S. Hussein? Okay, so hopefully not. Okay, hopefully Dr. S. Hussein would be watching our videos. So Dr. S. Hussein, if you are watching our videos, um, please let us know if you have anything that you would like for us to discuss regarding the pharmacology. Okay, and we want to thank you for your feedback. That's that. Okay. Having said that, since we are done with psychiatry, I think it's about time that we should move on. We should start with our renals. So what we are going to do is, do you guys remember that our initial study method, okay, that is that every day we would be reading 10 pages, 10 to 12 pages. And the reason why we failed to do so for the last 2 weeks, that's because for the last 2 weeks or so, we were dealing with topics which were as hard as neurology and which required us to go back and understand if everyone is understanding the whole thing or not, because neurology is extremely high yield. So we did not really want to rush through. We were not worried about the quantity of the lectures or the pages that were covered during the lecture. We were more worried about the quality by which the students would understand and master the concept. So today onwards, what we are going to do is we are going to go back to our previous method of reading first aid. That is, after reading the whole page, okay, so let's say we have an entire page of first aid, okay, I will try my best to read through them, make you guys understand, and help you guys out understand the whole page, okay. After reading the whole page, if you guys have questions regarding the page, only then can you guys ask me the question. And do not worry, we will not move on to the next page before we make sure that one page has been mastered properly by everyone. Okay, so if you guys have any questions regarding that page, please let us know when we ask you. But during the explanation, just try to keep your utmost attention and focus to the lecture so that this way we can stick to finishing the 10 pages. with maintaining the quantity as well as the quality of our lectures. And if you guys have any questions, please write them down in a separate page. And when we ask you if you guys have any questions or not, please let us know. Okay, we have a question from Dr. Karbasi. Okay, could you send the first aid PDF version? I don't know, but my version makes me problems. Okay, we have the free PDF of first aid 2020 on our page in on Facebook. That is Dr. Hideaway. Okay, if you can go over there, you can see that we have the first aid out there. All you have to do is search. Okay, there's a search option on our page. Just write first aid 2020, and when you do that, you will get a post from us where we have provided free first aid 2020 for anyone and everyone, all subscribed applicants and applicants who have not subscribed. So all you have to do is ask us to give you access. They will send us an email and we will provide you the access. Just a matter of a couple of seconds. Okay. So it's already over there. So please go and access the first aid PDF. Okay. Okay. So having said that, let's take 2 minutes. Okay, let's take 2 minutes and let's begin our renal embryology. Okay, we will take 2 minutes and we will begin our renal embryology just in case because usually we can you guys hear my voice? Is the voice breaking? Okay, so usually what happens is the student we usually start our lectures from 9:30, 9:45. So we just want to give all the other students another opportunity to join before we begin a new topic. So let's just wait for 2 minutes before we begin. Okay, thank you. Okay, so it's 9:31 as of right now. It's almost about time that we should begin our lecture for today. Okay, before we begin, we have another question from Dr. Hassam. Doctor, also about the neuro that we missed and the CT scans, pics, when do we do that? Okay, that's a very good question. The CT scan pictures that we are going to do, we are going to start that first thing next week, Monday. Okay, we were supposed to start it this week, Monday, but the problem was we have not been able to finish collecting all the high yield images. Okay, and we wanted to take a proper lecture of the CT scans. So if you guys do not have any problems, then we were hoping that if you can provide us with 2 more days. In that meantime, what we're going to do is you guys are going to have a neurology assessment exam this week, which will contain mostly of neurology questions. and psychiatric questions. And the whole purpose of the assessment exam of neurology is to make sure that you guys have understood the topic and so that successfully you can move forward to the topics in the future. Okay, so that's that. 1 second, please. Okay, so that's that. So is does that answer your question, Dr. Hassan? Okay, good. Okay, so everyone, please make sure to do the neurology assessment. And having said that, we should move forward. Okay, so I'm just going to share my image and we are going to begin. Okay, 1 second. Okay, so can you guys see my screen over here? Can you guys see my screen? Okay, perfect. Oh, 1 second. Okay. Okay, let's begin. Okay, so before we begin, we are the topics for renal and first aid are divided into the exact way how we discuss. That is embryology, physiology, uh, pathology, embryology, anatomy and physiology, pathology, and then we have pharmacology of the renal system. Okay, compared to neurology, renal system is not that difficult to understand when you compare it with neurology. But overall, the renal system is still very high yield, and a lot of things have to be mastered. And we will go through them easily one by one, and we will read each and every page and make sure that all the students have understood. If you guys have any questions, please remember to ask me when we're done reading the page. Okay, having said that, let's begin with our renal embryology. First of all, we will, before we jump into this text over here, let's do a little run back of embryology as a whole. So how about you guys help me out? Okay, so first of all, if a zygote is fertilized, I mean, if an ovum is fertilized and it forms into a zygote, okay, what happens in the first week? Can I get some fast answers, please? I have been discussing this uh, in every embryology topic. What happens in the first week? First week is not the week for gastrulation. First week is implantation. Very good. Okay, good. What happens in the second week? What happens in the second week? Second week, once again, is not for gastrulation. Second week is not for gastrulation. Second week is for the formation of the bilaminar disc. Okay. Second week is the formation of the bilaminar disc. What are the layers of the bilaminar disc, please? What are the two layers of the bilaminar disc? Fast answers, hypoblast and epiblast. Very good. And what happens in the third week? Now, Dr. Hossam, now you can say gastrulation. Okay, from the third week. Third week is gastrulation. Very good. Okay, gastrulation is the formation of the trilaminar disc. What are the layers of the trilaminar disc? What are the three layers of the trilaminar disc? Very easy to understand. The three layers of trilaminar disc: endo, meso, ecto. Okay. Now, how many parts does a mesoderm have? Mesoderm. What are the parts of the mesoderm? What are the parts? Lateral plate, and then what else? Intermediate, and then what else? Somatic, or somite, or splanchnopleuric. Okay, good. From which part of the mesoderm does the kidney arise from? Fast answers, please. From which part of the mesoderm? Very good. Okay, so the answer is intermediate mesoderm. Intermediate mesoderm. Are we all clear on this breakdown of the formation of the mesoderm and intermediate mesoderm and how everything is happening all the way from the beginning to right now? Are we all clear from all the steps, beginning from fertilization to implantation to bilaminar disc formation, trilaminar disc formation, and then mesoderm divided into three parts, and the intermediate one is important for the development of the kidneys. Okay. Having said that, now we can move forward since we have a strong basic on embryology. Now we can move forward. Now we can know what's going on over here. So we will start with kidney embryology. Okay. Okay. So before we do this, okay, before we do that, one more thing that I want to do is before I jump into the text, just want to use my blank page for 1 second and make you guys understand what's going on over here. Okay, 1 second. Okay, thank you for your cooperation and giving me some time. Okay, okay, perfect. Okay, good. So what's happening over here is, as we said, that the kidneys are developed from the intermediate mesoderm. Okay, so the first part of the kidney, okay, the first thing that develops in the kidney is a very primitive kidney. The word primitive for primitive kidney, the word is pronephros. Okay, the word is pronephros. Okay, this is a very primitive renal structure that does some functions of the renal system. The main function is filtration of the blood, so that's what it does very primarily. And the thing is, it stays till week 4. Okay, it stays till week 4, and then it degenerates. After week 4, it degenerates. Okay, how important is understanding that the pronephros stays till week 4? It's comparatively high yield. Okay, you will get 2 questions in U World regarding this knowledge over here. Okay, regarding this knowledge over here, and the way that you can remember that the pronephros only stays till week 4 is that is that is that professional players, okay, professional players only play for 4 days. Okay, if you have a whole week of a game, okay, the professional players will only play for 4 days because they're very professional. After 4 days, they will go away because that's how they're paid. Okay, so this is just a mnemonic to remember that pronephros will be there for only week 4. Okay, so that's that. So keep that in mind. Keep this small mnemonic in mind that the professionals in a game of any game, if it's a 1 week game, the professionals will play for 4 days. For 4 days, we said 4 days, but do not remember 4 days for week 4. But because the pronephros, it stays to for 4 weeks. Just try to remember the letter 4, and it should be week 4 because no primitive structure should stay for 4 days. That's just basic knowledge. Okay, so pronephros would stay for week 4. Next one, after it degenerates, after it degenerates, the second structure that forms is mesonephros. The second structure that forms is mesonephros. Okay, mesonephros, and mesonephros is this structure which will function as also another primitive renal structure till first trimester. So after week 4, there will be formation of the mesonephros, which will stay for first trimester. For first trimester, we basically mean more or less the first 3 months of the pregnancy. And after that, the mesonephros will not degenerate. They will contribute to the formation of the they will contribute to the formation of the male genital system, basically the mesonephric duct. That's what they're going to do. But for the first trimester, they will function as the renal structure. Okay, so we're going to jump into the drawing, but just before we do that, okay, just give us 1 more second. The next structure that will form is a very permanent structure, and this is metanephros. Okay, this is metanephros. This is not mesonephros, this is metanephros. Metanephros is a permanent, more or less a permanent renal structure which will keep on developing from fifth week, fifth week till 32 to 36 weeks of gestation. Fifth week to 32 to 36 weeks of gestation. Okay, so that's what's going to happen. So first of all, let's read the dates. I mean the days once again. First of all, we have a pronephros, which is a very primitive renal structure. This will form at week 4. After formation at week 4, they will degenerate, and the mesonephros will form after the pronephros and stay there till first trimester. After that, they will not degenerate. They will form and they will help into the formation of the male genital system. And then we have the metanephros, which will form from the fifth week, and it will fully develop by 32 to 36 weeks of gestation. Okay, having said that, over here, the only thing that we have to understand is pronephros is being degenerated at week 4. That's a question. Mesonephros, how it helps in the formation of the male genital system. Okay, this is another question. Okay, the fact that metanephros stays from fifth week to 32, 36 weeks, we have not come across any question which asks this. Okay, so if you want to remember, you can. If not, just try to remember that metanephros is a permanent structure. Okay, now what's going on over here is that the metanephros has two parts, that is ureteric bud. Okay, they have ureteric bud and another high yield structure that is known as a metanephric mesenchyme. Metanephric mesenchyme. Okay, so before we jump into that, let's just draw our structures over here for 1 second. Okay, so first of all, what we are going to do is we are going to draw the pronephros. Okay, so let's say that these two are the pronephros in the baby. Okay, and after that, the pronephros obviously degenerates. Okay, so this is to show that the pronephros are degenerating. Okay, so the rest of the parts of this green line over here are here to represent the degenerated segments of the pronephros. Okay, after that, the next thing that forms is obviously after pronephros, what we have is mesonephros. Okay, so mesonephros, this is forming over here, and this will stay for the first trimester. Okay, so this structure is the mesonephros, and the mesonephros is very well known for having a duct which will give rise to the male genital system. And this duct over here in the mesonephros, this duct is known as the mesonephric duct. Mesonephric duct. Okay, so that's that. And after that, after the first trimester, this structure will not form into the renal structures anymore. They will help into the formation of the male genital system. So that's that. Okay, and then the second, and then I'm sorry, the third thing that we talked about was the formation of the metanephros. Okay, the formation of the metanephros. So what they will do is, okay, they will do is just let me finish, and here we go. Okay, the metanephros, as I have said, they contain two structures, that is the ureteric bud and the metanephric mesenchyme. So this protrusion over here, this is known as the ureteric bud. Okay, these two for each two sides are the left and right ureteric bud, and we have the metanephric mesenchyme, which is over here, metanephric mesenchyme. Okay, okay, and this structure as a whole, okay, this structure as a whole, this structure is known as metanephros. That is the metanephric mesenchyme and the ureteric bud. This structure is known as mesonephros. Mesonephros. And obviously this one is the degenerated portion of pronephros. Okay, so that's that. Okay, and then we have another small structure over here, which we will discuss again when the time is right. That is, this structure is known as the urogenital sinus, okay, which will eventually help us in the formation of the bladder system. Okay, so ureteric bud and metanephric mesenchyme. Now, what's going on is the ureteric bud. Okay, so the ureteric bud. What happens is this develops from the caudal end of the mesonephric duct. So this is the caudal end of the mesonephric duct, right? This is the cranial end, this is the caudal end, and the ureteric bud, as we can see that the ureteric bud is being developed from the caudal end of the mesonephric duct. And after it develops, this duct over here is fully canalized. Okay, so duct canalization, meaning that if, let's say that this is a straight line, okay, let's say that once again, okay, let's say that this is the ureteric bud. Okay, and as you can see over here, that there is no proper canal in the middle. It's just a straight stem of line with no space for any fluid to pass through. So what happens is you need a formation of a canal in the middle like this. Okay, you need a formation of a canal in the middle like this, so that fluid can pass through the ureteric bud, or else how will it drain into the bladder, right? Because the ureteric bud is obviously um, the portion of the kidney which is okay. One second, please. Okay. So let's go back to the picture. Okay, so what we were saying was that the ureteric bud over here, this has to be canalized, okay? Because in order for the ureteric bud to be canalized, the fluid has to pass from the kidney all the way to the bladder through the canalization of the ureteric bud, okay? And what happens is this canalization of the ureteric bud, this canalization of the ureteric bud is completed at the 10th week, the 10th week. So the metanephro starts forming at the 5th week of gestation, and the ureteric bud canalization is completed at the 10th week of gestation. Okay, so that is another high yield information which you have to remember because you might get tested on it. There are several questions in MBOS which will test you on how long it takes for the canalization of the ureteric bud to take place. Okay. So obviously, if the ureteric bud is an embryological structure, then this embryological structure will give rise to a lot of matured renal structures. So what are the matured renal structures that are being developed from the ureteric bud? Basically, every part of the kidney every part of the kidney starting from um, the collecting duct, okay, starting from the collecting duct to the renal pelvis, callus, ureter, okay, all the way to the ureter. Everything will develop from here. So if anyone asks you, what are the structures that are being developed from the ureteric bud? If anyone asks you what are the structures that are developed from the ureteric bud, the answer is every structure. Let's say that this is the glomerulus, PCT, right? Then loop, and then DCT, okay? And then we have the collecting segments, and then we have the pelvis, callus, right? And then we have the ureter. So everything starting from over here, that is the collecting duct onwards, all the way to the ureter, all throughout this whole portion is developed from the ureteric bud. Okay, so that's that. Okay, and so if these are the portions that are developed from the ureteric bud, which portions of the kidneys are developed from the metanephric mesenchyme? That is everything from here to up to here. That is from the proximal convoluted tubule all the way to the distal convoluted tubule. Everything from this part is developed from the metanephric mesenchyme. From the metanephric mesenchyme. Okay, but in order for this proper development to occur, the ureteric bud at first, what happens is the ureteric bud grows and the ureteric bud interacts with the tissue of the metanephric mesenchyme. Okay, and this proper interaction. Okay, so let's say what's going on over here is, that this is your metanephric mesenchyme, this is your ureteric bud. Okay, so so the ureteric bud is going towards the metanephric mesenchyme. Only when the ureteric bud reaches the metanephric mesenchyme properly, this ureteric bud will induce proper differentiation and development of the renal structures. But for that to happen, the ureteric bud has to reach the metanephric mesenchyme properly and induce proper differentiations, because there are signaling pathways which provides a lot of signals, in order for the proper differentiation to happen. Okay, so what happens is after only there is proper interactions between the ureteric bud and the metanephric mesenchyme will these structures develop properly. If there is abnormal interaction, okay, let's say now we have an abnormal interaction between the metanephric mesenchyme and the ureteric bud, what would happen is there will be there will be multiple developmental and congenital malformations of the kidney. The examples of which are, for example, if there is improper interaction between the ureteric bud and the metanephric mesenchyme. Okay, the first problem that can happen is renal agenesis, or there could be other problems such as multicystic dysplastic kidney. Okay, multicystic dysplastic kidney. Okay, and out of all of this thing over here, okay, the only thing that we have to understand is the ureteric bud needs proper interaction with the metanephric mesenchyme in order for proper development of the renal system to occur. If there is improper interaction, then what would happen is there will be formation of the congenital malformations of the kidney. Okay. Last piece of information that you need from this whole thing over here is if anyone asks you which part of the kidney is the last to canalize, okay, last to canalize. Okay. Now what's going on is that the ureteric bud will canalize, obviously, because this portion will canalize, right? And there will be a formation of a canal so that the filtration of the blood, that is the filtered urine, can pass through this bud into the bladder. So the last piece of the renal system that needs to be canalized is the this this one. That is the uretero-pelvic junction. The uretero-pelvic junction. That is the last piece of the primitive renal system, the embryological renal system, to canalize. And the best thing is, since this is the last thing to canalize, there are times when this fails to canalize. When there is failure of canalization of this last portion of the ureteropelvic junction. So what happens is, if there is failure of canalization, this can lead to congenital hydronephrosis. Okay, we will talk about congenital hydronephrosis. In basic term, congenital hydronephrosis is basically the kidney being unable to drain the urine into the bladder. So the urine accumulates more or less in the kidney, and when urine accumulates in the kidney, the kidneys get large and big. That is known as hydronephrosis, more or less. Okay, so that's that. So this is what happens from congenital hydronephrosis. Okay, so once again, let's walk through the whole thing. Okay, for uh, our review purpose. Okay, first of all, the first part of the kidney to develop is pronephros, that develops at week 4, and then it degenerates. Okay, and the mnemonic that we used was professional players plays for 4 days. So four weeks for pronephros and four for pro. Okay, so that's that. After that, from the 5th week onward, we have the development of the mesonephros, which acts as the kidney till first trimester, and then it helps in the formation of the male genital system. From 5th week onwards, we have the formation of the metanephros. Metanephros has two parts: ureteric bud and metanephric, and the metanephric mesenchyme. Okay, the metanephros gives rise to the meat to the meat the I mean the mesonephros gives rise to the mesonephric duct, which helps in the formation of the male genital system. And from the caudal portion of the mesonephros, the mesonephric duct, you have the formation of the ureteric bud. That is the part of the metanephros, and you have the metanephric mesenchyme. Then there has to be proper interaction between the ureteric bud and the metanephric mesenchyme in order for the parts of the kidneys to develop. Okay, and there is a canalization of the ureteric bud, which is finished by 10th week. Okay, and the last portion to canalize is the ureteropelvic junction. The structures which are developed from the ureteric bud are all the structures from the collecting duct to the ureter, and the structures which are developed from the metanephric mesenchyme are all the structures from the proximal convoluted tubule to the collecting duct. Okay, having said that, now, does anyone have any question? Now, does anyone have any question after hearing everything? Is everything crystal clear or not? Any questions before we move forward? Ureteropelvic junction. Ureteropelvic junction is basically One question, the pelvic junction also add ureteric bud. Okay, so the uretero-pelvic junction. Okay, the uretero-pelvic junction. Oh, my bad. Oh, that's what you meant. Okay, right. I'm sorry. It actually should have been over here. Yes, my bad. I kept on thinking of the uretero-bladder junctions. Okay. Okay. Anything else? Any more question? Any more question? Is it clear? Do we have any questions before we move forward? Okay. So what are the structures that are developed from the ureteric bud? Yes. And female mesonephros degenerates and forms into paramesonephros. So that is something that we will study in reproductive system. Okay. What are the structures that are developed from the ureteric bud? Collecting duct. Two. Ureter. Okay. What are the structures that are developed from the metanephric mesenchyme? Okay, good. Okay. Okay. So has everyone understood the breakdown of the kidney structures? Does anyone have any confusion? Okay. So keep in mind that we made a mistake over here. Okay, we drew this thing over here. It should not have been over here. This is the uretero-pelvic junction. The uretero-pelvic junction is over here. Okay, my bad. There must have been a confusion when I was making the drawing. So that's that. Okay. So having said that, let's move on. Okay, let's move on with the explanations. Okay. Now we can go back to our text and see if we have covered everything more or less. So if you read the text right now, you will realize that we have covered every single details in this text over here. Okay, and out of all of this over here, we have covered everything, and we have also told you which parts are important for you to understand from where the questions are going to come. Okay, and which parts you have to focus on. Okay, so that's that. The most important question from over here, the most important question you go from over here that you will receive in your U world is the ureteric bud, the ureteric bud derivatives, the ureteric bud derivatives, and the metanephric mesenchyme derivatives. Okay, and only if they knew how brilliantly smart you guys are, then they would not ask you this question, because I'm pretty sure you guys would understand and answer these questions with confidence, that the fact that the ureteric bud gives rise to all the structures from the collecting duct to the ureters, metanephric mesenchyme gives rise to all the structures from the PCT to DCT. Okay, having said that, let's move on to the next portion of renal embryology. That is a very high yield embryological disease that is known as Potter sequence or Potter syndrome. Okay, so what's happening over here in Potter sequence or Potter syndrome? Okay, first of all, first of all, is the amniotic fluid content of is the amniotic fluid that is present in the womb, do you guys realize that that amniotic fluid is it contains the baby's urine? Urine, yes or no? Yes. Okay, pee of, okay, let's see who wrote pee of the baby. Okay, so Dr. No, pee of the baby, that is correct. Okay, so this PPO for over there on the womb in the amniotic fluid. Okay, do you also realize that the baby drinks the amniotic fluid and then it recirculates in the amniotic fluid? Okay, perfect. So this knowledge is there. So that's a very basic knowledge. That is, in the womb. Okay, so we have the amniotic fluid, and then we have this little baby. Okay, we have this little baby over here, and the baby does the PP, and then the PP is the main content of the amniotic fluid, more or less, and then the baby drinks the PP, and then this is how this is how the circulations of the fluid in the this is how the circulations occur in amniotic in the amniotic cavity. Okay, so what's going on over here is that in order for the baby to do the PP properly, okay, the babies need to have a proper functioning kidney. Okay. Now, for some reason, as we have said before, that the ureteric bud has to be properly um, interacted with the mesonephric mesenchyme, and if that doesn't happen properly, then you can get a lot of problems. Okay, um, you can get multicystic dysplastic kidney. You can get another one was, what was the another one that we have said, that is renal agenesis, right? Then even if there is a ureteral bilateral ureteral pelvic junction obstruction, then you will get bilateral hydronephrosis, and also that's that. So what's happening is, if the baby does not complete the urinations properly, then the fluid inside the amniotic cavity will decrease, and as a result, for the decreased amniotic fluid, the condition that will happen is oligohydroamnios. And what would happen is, if there is decreased amount of amniotic fluid, this will compress on the babies, on the developing fetus. Okay. And we know that the baby stays in a fetal position, and they need space inside the amniotic cavity for proper growth and differentiation of the limbs and the face and all the structures of the baby. So what would happen is, since there is no room for growth, there will be decreased space. So the baby will have limb deformities, right? And the baby will also have facial anomalies like low set ears, retrognathia. Okay, retrognathia, as you can see over here, that is depressed or and pressed out. I mean, a pressed in jawline. Okay, flattened nose. Nose will also be flattened. Okay, so basically, it's as if, let's say that this is the normal amniotic cavity, and in oligohydramnios, well, what's going on over here is, in oligohydramnios, what's going on over here is, let's say that, one second. Okay, let's say that this is the amniotic cavity right now with this little baby over here. Okay, there is absolutely no room for the baby to grow, so everything is pressing on the baby. So the baby has flat nose, retrogranthia, low set ears. Along with this, when the baby drinks the amniotic fluid, this fluid helps out in stretching of the lungs. Okay, this fluid helps out in stretching of the lungs, so the baby can have a proper development of the respiratory system. And what happens is, if there is oligohydramnios, if there is oligohydramnios, then what would happen is that the baby can have pulmonary hypoplasia, because there will not be enough amniotic fluid for the baby to eat and then stretch out the lungs. So there will also be pulmonary hypoplasia, and this is one of the most important cause of death for babies with Potter sequence. What are the causes of Potter sequence? First of all, we mentioned the cystic causes. Then there is ARPKD, meaning autosomal recessive polycystic kidney disease, obstructive uropathy, or for example, posterior urethral valves, bilateral renal agenesis, and chronic placental insufficiency. Out of everything over here, one of the most important causes, ARPKD, autosomal recessive polycystic kidney disease. Okay. And they also have a mnemonic for you, so that you can remember all the high yield Potter sequence images. I mean, the conditions. That is P for pulmonary hypoplasia, O for oligohydramnios, which is the trigger, T for twisted face, twisted skin, E for extremity defects, and R for renal failure in utero renal failure. Now, I'm pretty sure this is very easy to understand. My question to you guys is, can you guys tell me one condition which we talked about in GI system where patients will have polyhydramnios? What is the one condition in GI system in which patients will have polyhydramnios? Esophageal atresia. Okay, very good. Another condition? Can polyhydramnios also occur in? Very good. Atretic type of tracheoesophageal fistula, duodenal atresia. Okay. Okay, good. So have we understood oligohydramnios and Potter's sequence and Potter syndrome? Okay, do we have any questions or confusion on this page before we move on to the next page? Okay, good. Okay, so let's move on to the next page over here. So the next page is basically, pretty sure they're going to discuss about horseshoe kidney, okay, and then some congenital malformations of the kidney before we move on to renal anatomy, okay. So just give me 1 second so that I can discuss about the horseshoe kidney. Okay. So horseshoe kidney is a very important it's a very important topic for USMLE step one. Okay. And a very interesting topic too. And the thing is horseshoe kidney, what's going on over here is that the inferior bulbs, okay, let's say that this is this is one kidney. 1 second. Mhm. Okay. This one. Please give me 1 second. I apologize. Okay. So let's say that this is one kidney, okay, and this is another kidney. Okay. Now the inferior poles of both of these kidneys should be independent of one another. They should not be fused. Okay. Horseshoe kidney is that problem when the inferior poles of these two kidneys they fuse abnormally. Okay. There's a fusion abnormality. Okay. So that's what it is. So there's a fusion abnormality, and what happens is the kidneys in the beginning, they usually stay in the lower abdomen. And what happens is, as we develop and we are fully matured, the kidneys they keep on rising up, okay, all the way up to the renal angle. Okay, if I mention the renal angle, can you guys tell me the vertebral level at which the kidney is usually present? Everyone. Okay, so the kidney it usually stays on a more lower level. So very good. So the kidney stays usually in a more lower level, and gradually it ascends upward. Okay, but what happens is if there's a fusion, okay, if there is a fusion of the kidneys like this, and it looks like a horseshoe, when they start to ascend upwards, there's a very important organ. I mean, there's a very important structure which prevents the ascent of the kidney. This important structure over here. Okay, this important structure is a very important artery. Okay, and this artery is known as IMA, inferior mesenteric artery. This artery is the one where the horseshoe kidney gets stuck, and obviously they cannot pierce through the artery, right? Because it's not a first of all it's not a sharp organ, and then second of all it's not destructive, so they will not pierce through the artery. Okay, so they remain in the lower abdomen, and the function of the kidneys are usually not hampered. The kidneys they usually function very well, and the important thing is this is only found out in incidental imaging. For example, let's say that the patient has to do a CT scan for another condition, and when they do the CT scan, only then they can see that the patient has a horseshoe kidney, because the patient did not have previously any signs and symptoms for the horseshoe kidney. Although having said that, having a horseshoe kidney still puts the patient at risk for formation of kidney stones, okay, and infections infections. Okay, so these are the two problems which the patient can have. Also, the patient can have increased risk of RCC, meaning renal cell carcinoma. Okay, the most important question that you will receive from over here is that the kidneys get stuck at the IMA level, at the IMA, and they do not ascend upwards because of the presence of this structure, that is the inferior mesenteric artery. Okay, and there are a couple of high yield congenital anomalies where you can see these horseshoe type of kidneys, and the congenital anomalies are thankfully and unfortunately fortunately all the trisomies. Okay, so we have trisomies 13, 18, and trisomies 21, and you can see this in all the trisomies. Okay, so that's that. Okay, so if you can see that this is the CT scan. Okay, and this structure over here is the horseshoe kidney, as you can see. And if I have to ask you about this artery, okay, what is the name of this artery? Fast answers, please. Okay. So for the students who have said abdominal aorta, why is this abdominal aorta? Why is this abdominal aorta? Okay. Okay. So the thing is is inferior mesenteric artery a branch of the abdominal aorta? Okay. Good. Is the inferior mesenteric artery um a bigger artery than abdominal aorta, or a smaller artery? Smaller artery. Okay. So if we do a CT scan, which artery will be easy to be visualized? The abdominal aorta or the inferior mesenteric artery? Okay. Okay. Now, okay. Now there are two types of questions that will come. Okay. There are two types of questions that will come. Now it all depends on the resolution of the CT scan. Okay, this is one thing. So the next time when you guys receive questions, the next time when you receive questions on CT scans and to identify the arteries, please try to look out for two types of CT scans. One is HRCT, another one is LRCT of the abdomen. Okay, so when they do a high HRCT and when they do an LRCT, so in which type of so HRCT is basically high resolution CT scan. LRCT is low resolution CT scan. In which type of CT scans can you see smaller structures properly? Okay, so if there is a CT scan where you can see the smaller structures, then there is a possibility that you can see that the horseshoe kidney is nicked at the inferior mesenteric artery. But if they mention that the CT scan is not a it's not a high resolution one, okay, then okay, if it's a lower if it's of a lower resolution CT scan, then the structures that is nicking the horseshoe kidney, it could be abdominal aorta. So it all depends on the resolution of the CT scan. If they do not mention the CT scan resolution, then directly your answer should be abdominal aorta. Am I clear about this? Am I clear about this? Okay. Okay, where will you get these type of questions? Amboss. Okay, you will get these type of questions in Amboss, not in UWorld. Okay, you will, if anyone is solving Amboss, do we have any students over here who is actively solving Amboss? Anyone who's solving Amboss? Okay, so if you guys are solving Amboss, if you guys are solving Amboss, then you guys will get these type of questions in Amboss. Okay, next one. Next one is a congenital solitary functioning kidney. Okay, so what is a congenital solitary functioning kidney? This is a condition of being born with only one functioning kidney. Majority is asymptomatic with compensatory hypertrophy of contralateral kidney, but anomalies in contralateral kidneys are common, often diagnosed prenatally by ultrasound. So what's going on over here is that over here, the patients have both kidneys, but only one kidney is functioning. Okay, and the majority is asymptomatic. They will not have any symptoms except the fact that the asymptomatic majority will be asymptomatic with only compensatory hypertrophy of the contralateral kidney. Why will there be compensatory hypertrophy of the contralateral kidney? Can anyone give me a proper explanation? Why will there be a compensatory hypertrophy of the contralateral kidney? Okay, which kidney will be hypertrophied, the working one or the not working one? The functional kidney. Very good. Okay, so obviously, so obviously, if we have two kidneys over here, if one is functioning more, then they'll have then they will have physiological hypertrophy. Okay, physiological hypertrophy, and that's that. So one kidney will be larger than the other kidney, and This is not that high yield. The only thing that is compensatory hypertrophy, that's that. Okay. Next one is unilateral renal agenesis. Okay. Do you remember how I told you that the ureteric bud has to go and fuse with the metanephric mesenchyme in order for the development to be completed? Now, for some reason, if the ureteric bud fails to develop and induce the differentiation of the metanephric mesenchyme, what happens is there is complete absence of the kidney and the ureter. So basically, the metanephric mesenchyme, okay, okay, understand this that the the metanephric mesenchyme over here, okay, that the metanephric mesenchyme. This is a very important thing for you to remember. Thus, the story. Okay, so the metanephric mesenchyme is long awaiting for the ureteric bud. Okay, so what happens is the ureteric bud, it keeps on coming over here, and the metanephric mesenchyme, it keeps on looking at the ureteric bud. Okay, just telling him, okay, you're almost here, you're almost here, or you're almost here. I've been waiting for you for so long, so long. And then what happens is out of nowhere, the ureteric bud fails, and it does not go to the metanephric mesenchyme. Obviously, since the metanephric mesenchyme has been waiting for so long, and the ureteric bud does not come, okay, the metanephric mesenchyme, being how she is, she does not wait, and what she does is she leaves, she goes away. If the metanephric mesenchyme goes away, the ureteric bud is just there, all upset and sad. Okay, so what happens is a huge portion of the kidney is absent, right? That is the main portion. That is from the PCT to the DCT. That portion of the kidney is absent, and the remaining portion that was supposed to be formed from over here, that's also absent. As a result, what you have is you have a unilateral renal agenesis. Okay, the whole portion of the kidney is absent. So the whole one-sided segment is absent. So that's that. Another one is another one is that the ureteric bud goes to the metanephric mesenchyme. The ureteric bud goes to the metanephric mesenchyme, but over there, what happens is after it goes to the metanephric mesenchyme, the ureteric bud fails to induce the differentiation. Okay, so let's say that the ureteric bud over here, it keeps on going forward. Okay, the ureteric bud, it keeps on going forward. Okay, it keeps on going forward, and then once it comes over here, it fails to induce any differentiation, so nothing happens. Okay, there's no difference. The metanephric mesenchyme was long awaiting for the ureteric bud to come so that they can have a chat, okay, have a good time. But over there, when he goes and he has nothing to say to her, okay, there's no differentiation, there's nothing. So what happens is, as a result, it's a non-functioning relationship in between the metanephric mesenchyme and the ureteric bud. So as a result, what we have is a multicystic dysplastic kidney. That is a non-functional kidney. The kidneys are not functioning. And whenever there is a non-functional kidney and it fails to induce any type of differentiation in the metanephric mesenchyme, the parts of the kidney which were supposed to form the matured structure, they end up being like cysts and connective tissue. Okay. And what happens is, if it usually stays bilateral. I mean, it usually stays unilateral, but if it's bilateral, then that could lead to Potter sequence. That could lead to Potter sequence. Okay. So these are the things that's happening. First of all, the ureteric bud fails to go, and then the second one is the ureteric bud goes, but the ureteric bud is not interested to have any conversation. So the relationship becomes a non-functioning relationship. Okay. Next one is a duplex collecting system. Okay, duplex collecting system. What is the duplex collecting system? Basically, okay, now look what the ureteric bud does. Okay, now what the ureteric bud does is the ureteric bud, okay, this is what's going on with duplex collecting system. Duplex meaning that two. Okay, this ureteric bud is not a very loyal ureteric bud. Okay, this ureteric bud is not a very loyal ureteric bud. So what it does is, before it goes over here, okay, there is bifurcation of the ureteric bud, meaning that this ureteric bud is also interested in another metanephric mesenchyme, apparently. Okay, so as a result, what happens is this creates a Y-shaped bifid ureter. Okay, and But what happens is the metanephric mesenchyme, okay, she is also very smart. So she sees this, okay, she sees that the ureteric bud is trying to become unloyal, okay, so she pulls the ureteric bud, she pulls the loyal and the unloyal part of the ureteric bud towards her, okay, and as a result, what happens is this metanephric mesenchyme is now being induced and differentiated by two portions of the ureteric bud, okay, and as a result, what happens is this can cause a lot of problems. First of all, the problems that can occur is abnormal induction and
Excuse,
differentiation of the structures in metanephric mesenchyme.
excuse
And
me.
I'm
Look,
sorry.
okay,
Yep.
okay, okay. But someone waiting. Thank you.
Yep.
Bye.
Uh, Thank you so much. Okay. So what happens is the ureteric bud interacts with the kidney. Okay, that's that, and it causes an abnormal differentiation of the metanephric mesenchyme. And another one is this can also lead to ureteral obstruction, ureteric obstruction. Okay, because as you can see that the path of the urine right now is not a straight line. It's a very complex line, so there could be ureteric obstruction. And since there is some amount of stasis of urine, by stasis I mean slow flow or decreased flow of urine through the ducts, this long standing urine in the kidney can also give rise to UTI or pyelonephritis. Okay, so there are multiple problems that could be occurring with a duplex collecting system. Okay, so this is basically bifurcation of the ureteric bud before it enters the metanephric blastema, creating a Y-shaped bifid ureter. Okay, so Y-shaped duplex system can alternately occur through two ureteric bud reaching and interacting with the metanephric blastema, strongly associated with vesico-ureteral reflux, ureteral obstruction, and UTI. Okay, that's that. So I hope you guys have understood the duplex collecting system. The last thing that I want to talk about before I ask you whether you have any confusions or questions or not is the posterior urethral valves. Okay, what is the posterior urethral valves? Okay, so what's happening is the membranic remnant in the posterior urethra in the males, okay, its persistence can lead to the urethral obstruction. So this posterior urethral membrane usually degenerates. Okay, this is the portion of the urethra which usually degenerates. But if it usually stays, if it usually stays or it persists, then this can lead to urethral obstruction. Okay, so the most important question from over here is what is the cause of posterior urethral valve? The posterior urethral valve, the most important cause is persistence of the membranic remnant of the posterior urethra in males. This can be diagnosed prenatally, but what's happening over here is, as you can see, that if there is a posterior urethral valve, there could be bilateral hydronephrosis. How? Because the bladder over here, okay, the bladder cannot empty, and as a result, the bladder will put pressure, and this ascending pressure over here will put pressure on the kidneys, and as a result, there will be bilateral hydronephrosis on both sides. Okay, on both sides, there will be bilateral hydronephrosis. Then this is the most common cause of bladder outlet obstruction in male infants. So if we have a male infant, just how in adults, the most common cause of an adult male, the most common cause of bladder outlet obstruction is either BPH, okay, that is a benign prostatic hyperplasia. The most common cause of bladder outlet obstruction in young males or male infants are posterior urethral valves. It is also associated with oligohydramnios in cases of severe obstruction. In case of severe obstructions, as you know, as we have just said, that the proper functioning of the kidney and its structure is important for maintaining the contents of the amniotic fluid, because the most of the portions of the amniotic cavity is basically the pee of the baby. Okay, so since the baby cannot do the pee properly because of the presence of the posterior urethral valves, so those mothers can also get oligohydramnios. Okay, having said that, now do we have any question? Now do we have any question? Have you guys left the lecture? Okay, since I'm doing a little bit less interaction with you guys, have you guys left my lecture already? Okay, good. Thank you so much for being here. Do you guys have any question? Okay, Can you repeat the part for bilateral hydronephrosis? Of course. Okay. So what's happening in bilateral hydronephrosis is, let's say this is one kidney, this is another kidney. Okay. Both of them are draining into one bladder. Okay. This is the bladder. Okay. Okay. If there is a posterior urethral membrane which is obstructing this bladder over here will be full. This will put pressure in this kidney and this kidney. As a result, this two kidneys cannot drain their urine in the bladder, and both of them will have bilateral hydronephrosis. Okay, hope that answers your question. Next one, duplex collecting system. Can you repeat duplex collecting system? Of course. Duplex collecting system is basically your loyal is duplex collecting system the story about the loyal ureteric bud or the unloyal cheating ureteric bud, the ureteric bud which has the tendency to cheat, the cheater, okay, the unloyal one, okay. But is the metanephric mesenchyme any less than a very strong and independent 20 modern age 2020 women? Meaning that, will the metanephric mesenchyme let the ureteric bud go away, yes or no? Or will it pull the ureteric bud towards them and beat the shit out of them? Okay, it will pull them. Okay, so what's going on is that the ureteric bud over here, he was supposed to be loyal and straight and go straight to the metanephric mesenchyme, but what he did was he wanted to go and try some other things. Okay, he wanted to go and see how many fishes there are at the sea. Okay, but this metanephric mesenchyme, being how she is, okay, she will not let him go. She will not let him go. She will let him go, obviously, maybe later, but she wants to call him, both portions of him, towards herself so that she can beat the shit out of him. Okay, so that's what's going on with duplex ureteric bud. So the duplex ureteric bud takes a chance but does not succeed, and then both of them go and enter the kidney. But the problem is this duplex ureteric bud, when it goes and enters the kidney, this induces an abnormal differentiation of the kidney. Okay, and this can give rise to urethral obstruction, risk of UTI, and also vesico-urethral reflux. Are we clear? Okay. Next one. I don't get why it's possible to be a membrane remnant in the posterior urethra. Okay. The posterior urethra has anterior membrane and posterior membrane. Both of these membranes are supposed to degenerate, okay, so that there could be proper functioning of the bladder. But for some reason, if the posterior membrane that does not degenerate, then persistence of that membrane can cause obstruction of the bladder. Are we clear? That is called posterior urethral valve. Okay. Any more questions before we move forward? Okay. Did the story about the ureteric bud and the metanephric mesenchyme help you guys out or confuse you guys even more? Okay. The reason why I associated that story is because at any point, even if you forget the text, it's hard to forget a story. Okay. So even if you try to remember, let's say at one point that, okay, let's try remembering what the duplex collecting system is. Okay. Just try to remember about the unloyal ureteric bud and how the metanephric mesenchyme pulled it towards themselves. And you will be able to answer all the questions. Okay. Having said that, let's move forward. Okay. Now we will go to renal anatomy. Okay, now we will go to renal anatomy. Okay, how many of us are well acquainted with renal anatomy? I mean, this piece of information over here, because this is a very this is a very basic information which should have been mastered in bachelor's. But having said that, we still have gone through so many years before. I mean, after after we have completed our bachelor's in medicine and surgery. Just want to know how well you guys understand this thing. You had a question. Yes, Dr. Negi, what is your question before we start this chapter? What is your question, please? What is your question? Difference between unilateral renal agenesis and Multicystic dysplastic kidney. Okay. Unilateral renal agenesis is complete absence of the renal system. Multi. Okay. Okay. Unilateral renal agenesis is basically failure of the ureteric bud to interact with the metanephric mesenchyme, and then you have unilateral renal agenesis. Multicystic dysplastic kidney is when the ureteric bud succeeds to interact with the kidney, but it has caused an abnormal differentiation of the renal structures. Are we clear? One is failure of interaction, another one is abnormal interaction. Okay. Okay. Now, my next question to you guys is, how well do you guys understand the renal anatomy? That is the blood flow through the renal system. Because depending on this, I will draw a diagram or I will just explain the text in the first aid. Either way, I will explain the text in the first aid, but okay. So let's try reading the text in the first aid first. If anyone has any problems, please tell me so that I can, after that, I will draw the diagram out for you. Okay. So what's going on from over here is this is the part where we have to understand what's going on. Okay. So, okay. First of all, first of all, how many types of capillaries does the kidney have? How many, I mean, how many capillaries does the kidney have? Capillaries. Okay, I'll draw the diagram. Yes or no? Do you guys know how many capillaries? Okay, good. Peritubular. I just wanted to hear you guys say peritubular capillaries, okay, because it's really important. Okay. So first of all, what's going on over here is, okay, so diagram. Okay. Before I draw the diagram, let's just draw this first because this diagram is too complex to draw. Just, I will try my best to explain this diagram over here. Okay, so what's going on over here is that the left kidney is taken during liver transplantation because it has a longer renal vein. Okay, this piece of information is very, very, very important. This piece of information over here in your textbook, please give it 3 stars. Okay, 3 stars meaning you will obviously get this question in your multiple times and even a high possibility you will receive this question in your actual exam. The left-sided kidney is taken during transplantation because it has a longer renal vein. Okay, why is that happening? Okay, what's going on over here is that um, over here, what's going on is, let's say that this is your patient. Okay, okay, this is your patient over here, and this is the right side. This is the left side. This is the kidney, right kidney. This is the left kidney. Which side do we have the inferior vena cava? Right or the right side? Okay, so the inferior vena cava over here. Okay, the inferior vena cava over here is on the right side. Okay, if the inferior vena cava is over here on the right side, then the right kidney should have a vein like this, and the left kidney should have a vein that is like this. Okay. Now, if I ask you which vein over here is longer, the right vein or the left vein? The left vein, right? Yes, the left renal vein is longer. If the left renal vein is longer, does it allow the surgeon to have more area of the vessel to work on in order to take the kidney out properly during transplantations? Yes. So for this result, for this reason, the left kidney is always used for a transplant because it's easier to take out the left sided kidney because the left renal vein is longer. That's that. Okay. Okay. Then we have afferent and efferent. We all know what afferent is. Afferent is arriving, efferent is exiting. What's going on over here is that we're going to talk about the renal blood flow. So first of all, we have the renal artery. So the heart pumps the blood. Okay. After that, it goes to the arch of the aorta, then all the way to the descending aorta, then the abdominal aorta. Then from the abdominal aorta, it goes to the renal artery. From the renal artery, the first portion that it goes to is the segmental artery. Okay, so there are different segments of the renal artery, one, two, okay, three. Okay, so it will go to one of the segments of the renal artery. From the segments of the renal artery, it will go to the interlobar artery. They will go to the interlobar artery. As you can see over here that they have mentions of the interlobar, that is the arteries that goes to the lobes of the kidney, interlobar artery. From the interlobar artery, where they will go is they will go to the inter they will go to the arcuate artery. Okay, this arcuate artery that is over here, as you can see, that from the interlobar artery they will go to the arcuate artery. From the arcuate arteries are basically the boundary arteries, the arteries which are supplying the boundaries over here. They will go to the lobules, the small lobules. So at first we have the lobe, then we have the boundary, then we have the lobules. That is the interlobular artery. Okay. From the interlobular artery, where they will go is they will go to the efferent. Okay, they will go to the efferent arteriole of the glomerulus. Okay, from the efferent arteriole of the glomerulus, they will go to the glomerulus, and then after being filtered over here, they will go to the efferent arteriole. Okay, they will go to the efferent arteriole, and from the efferent arteriole, they will go to another part, that is the vasa recta or the peritubular capillaries. Okay, so there is another group of capillaries which are running all the way over here. Okay, so these are the peritubular capillaries. The peritubular capillaries are important for absorbing the reabsorption of the most of the substances from the kidney. Okay, and from there, from the peritubular capillaries, they will go to the venous system, and from there they will go back to the inferior vena cava. Are we clear on this? Are we clear on this? Yes or no? Okay, good. If you have any questions, please keep it. Let's keep it to ourselves, and I will give you the time to ask me the question so that we can finish it, and then go back to your questions that I can answer. The left renal vein, it receives two additional veins. That is the left suprarenal and left gonadal veins. The left renal vein over here, okay, the left renal vein, it receives two other additional veins. That is the suprarenal. That is the one which goes to the adrenal gland, and the gonads, the left gonadal veins. Despite the high overall renal blood flow, this is not that high, you'll to understand. Despite the high overall blood flow, renal medulla receives significantly less blood flow than the cortex, and this is very sensitive to hypoxia, and this is vulnerable to ischemic damage. This is a very important question, and this is a very important part from where a very important question will come. Not one, at least three to four. That which part of the kidney is more prone to ischemic damage, the cortex or the medulla? Your answer should be the medulla, because even though the renal system, the renal kidney, they have a high blood flow, the medulla receives a significantly low amount of blood, and it is very sensitive to hypoxia, so it's vulnerable to ischemia. Okay, so I'm just going to give it star, 2 stars. Okay. Okay. Now, there are another things that I want to talk about. Okay. I'm not sure. I'm sure they will talk about this in the future, but I just want to talk about this since these are already here. Okay. Over here, what you see is, okay, over here, what you see is, you see that there are some podocytes, okay, which are responsible for forming the forming the basement membrane. Okay. So the podocytes are over here. Okay. We also have the mesangial cells, and we have the macula densa and the juxtaglomerular cells. Okay, we will talk about the functions of these four structures in more details in renal physiology. But as for right now, for the picture part, I just wanted to point it out that these structures are over here. So we have the podocytes helping out with the basement membrane, mesangial cells, juxtaglomerular cells, macula densa cells, and the distal convoluted tubule. I have no doubt that you guys understand the functions of these cells. But if any of you don't, then do not worry. Just identify the structures over here right now, and we will talk about them in details in the future when we study renal physiology. Okay, having said that, have you understood this page? Do we have any questions? Do we have any questions from this page? Okay, so how do you guys feel about the renal system so far? Easy? No, not easy. Should be very easy. Okay, compared to neurology, should be very easy. Are you guys understanding the lecture? Okay, PIC is high yield. I will tell you about the high yield pictures. Okay, electronic microscopy is high yield or not high yield. Electronic microscopy of the kidney. Electronic microscopy of the kidney is high yield. I will talk about this in details when we talk about the pathology. Okay, okay, because that's how you can really differentiate the physiology from the pathology. Okay, so far all good. Okay, then let's move forward. Okay, let's move forward. Okay, cores of the ureters. Okay, what are the cores of the ureters? Let's talk about the ureters for a while. Okay, okay. So the ureters are basically they will drain the urine from the kidney into the bladder. Okay, so the cores of the ureters that's over here. Okay, they arise from the renal pelvis. They travel are under the gonadal artery. Okay, first of all, renal pelvis, renal renal pelvis. Okay, okay. A or B? Which one is the renal pelvis? A or B? Renal pelvis. Okay, A, B, C. Now, which one of A, B, C is the minor callus? Minor callus. Which one is the major callus? Which one is the major callus? Which one is the pelvis? Very good. A, B, C. So that's that. Okay, just wanted to see if you guys are well acquainted with this. Okay. So the cores of the ureters, they will basically arise from the renal pelvis. Okay. They will travel under the gonadal arteries and over the common iliac arteries and then under the uterine arteries. Okay. So what's going on is the course of the uterus. So for this, what I usually do is I draw a diagram. Okay. So the course of the ureter, they rise from the renal pelvis, they travel under the gonadal artery. So at first, what I'll do is this is the gonadal artery. Okay, just a very rough diagram. Okay, and this is travel under the gonadal and over the common iliac. Okay, this is the common iliac. Okay, and this is your okay. If you guys want, please draw this diagram out too, so that you guys do not make this mistake. So this is the ureter. Okay, this is the ureter over here. Okay, so the ureter will now pass under the gonadal. Okay, so it's going under the gonadal and then over the common iliac. So like this. So it's going under the gonadal artery and then over the common iliac. If you draw a diagram with a red, green, and a blue, okay, your brain will remember colors more than anything else. Okay, so if you draw this small diagram over here, you do not have to master this text because this is a very important text and you will receive a lot of questions from over here. Okay, you will receive a lot of questions from over here that when we have a gynecological operation, okay, if you want to cut or if you want to do any type of anastomosis with the uterine artery or clamp the uterine artery, okay, or we have like anything else, then we have to be very careful that you don't cause any damage to the ureters because the ureters are just under just under the uh, the gonadal arteries. Okay, and they are just over the common iliac arteries. So that's that. So please draw this diagram so that you do not make this mistake in the future, that which artery is over the ureter and which artery is under the ureter. Okay, next one. The gynecological procedures may damage the ureter, as I have just said, and this can cause urethral obstructions or leak. Okay, so this is the reason why this is important. Okay, you will receive a lot of questions from this association of this anatomy. That is the ureter. The ureter goes under the uterine and over the common iliac. Now, blood supply of the ureter. Okay. Do you guys remember that we talked about the blood supply of the ureter when we were discussing about the ureter in UWorld? We talked about this once. We will talk about this again, but we talked about this already. Do you guys remember that we talked about the blood supply of the ureter? Yes or no? Anyone? Even no is an answer? Yes or no? Very good. Okay, good answer. Okay. Okay, good. So thank you for answering. Okay. So the thing is, even if it's a no, it's not a problem because we don't mind going it over and over again. Okay. And that's the best way to review and recap all the information together. Okay. So first of all, proximal, middle, distal. The proximal portion over here, the proximal portion over here is this portion that is supplied by renal arteries. The middle portion over here, this is supplied by gonadal, aorta, and common and internal iliac. So common and internal iliac. Okay. And the distal portion over here, this portion, this is supplied by internal iliac and superior vesical artery. Superior vesical artery. Okay. This is very easy to understand. I'm going to tell you how. Okay. This is the portion of the ureter which stays really close to the kidney and the renals. So obviously this is the portion that is supplied by the renal artery. The distal portion stays really close to the bladder. We know that the bladder has supplied by the vesical arteries. So the superior vesical arteries will supply the superior portion of the bladder along with the distal segment of the ureter, along with the internal iliacs. Okay. And the middle portion over here, this portion contains the common and internal iliac arteries and also the gonadal and aorta. So this is the portion that will be supplied by the rest of the arteries that are left, that is gonadal, abdominal aorta, common and internal iliac arteries. So this is very easy to understand if you understand the associations of the different segments. Okay. Now there are three common points of ureteral obstruction. The first segment is in the ureteropelvic junction. The second one is in the pelvic inlet. And the third one is in the ureterovesicular junction. I want to draw a small image over here. Let's say that this is the kidney, one-sided kidney. This is the ureter that is going through here. And then, okay, this is the bladder. Okay. And over here, what we have is we have the pelvis. Okay, over here, what we have is we have the pelvic inlet. Okay, we have the pelvic inlet at this level. Okay, so there are three portions where there could be obstructions. First of all is this portion, that is the ureteropelvic junction. The second portion is in the pelvic inlet, this portion over here. The third one is over here. Okay, these are the three portions where the ureter can get pressures. The first one is the pelvic junction, pelvic inlet, and then the uretrovesicular junction. Okay, that's that. Okay. Let's try discussing a little bit about the bladder over here. Okay, so in the bladder we have the detrusor, the detrusor muscle. Okay, then we can, as you can see, there's the ureter which is entering the bladder. Okay, the uterine artery just above the ureter. Okay, like this one over here. It's in front of the ureter, the uterine artery. Then what we have is the median umbilical ligament. Okay, the trigon and the prostate over here. Okay, having said that, have we understood the text till now? The course of the ureter? Yes or no? Okay. Can we do a small revision and recapitulation before we move on to renal physiology? Blood supply of the ureter. Okay. What is the portion of the ureter? Which portion of the ureter is close to the kidney, the proximal or the distal one? Dr. Hassan? I'm sorry, Dr. Krabsi, the proximal one. No, so the proximal portion of the ureter is supplied by the renal artery. Which segment of the ureter is close to the bladder? Distal. So the distal segment of the ureter is supplied by superior vesical artery and internal iliac artery. Which portion of the ureter is close to the abdominal aorta? Middle. So the middle portion is supplied by aorta, common, and internal iliac. Okay, very good. And the gonadal artery. Okay. First of all, before we move forward to renal physiology, I would just want to make sure that we have mastered the concepts of first aid. So, in order for us to understand that you have understood, I have to ask you some questions, and you have to answer them properly. I am very, very confident that each and every one of you will succeed in doing so. So, once again, who are the students who are confident to answer my questions? And even if you are not confident, even if you want to participate, this will be good for you because if you make mistakes, you will remember those mistakes way better than if you do not make mistakes. Okay, very good. So we have three students already. So our first student, Dr. Assam, let's begin with you. Okay. What is the first call? What is the first? Okay, so you can unmute yourself so that I can understand you more clearly and get this process done with faster. Okay. What is the first primitive renal structure that degenerates at week 4?
It's prophase.
Pronephros.
Pronephron.
Pronephros. Very good. Okay, so pronephros. What happens after pronephros degenerates? What is the next structure?
Mesonephron.
Mesonephros. Which part of the mesonephros is important for giving rise to the male genital system?
Mesonephric duct.
Mhm. How long does the mesonephros stays?
Um, how long?
To first trimester.
First trimester, yeah.
Very good. Okay, first trimester. Next one is what happens after mesonephros?
Metanephron.
Metonephros. How many parts does the metonephros have?
Metanephric bud, yeah, ureteric bud and
Meton-
metanephric parenchyma.
Metanephric mesenchyme. Metanephric mesenchyme. Also, another name for metanephric mesenchyme is metanephric blastema. Okay, so metanephric
Uh-huh.
blastema, metanephric mesenchyme. Okay. Now, if I have to ask you, which segments of the kidney are developed from the ureteric bud?
From ureteric bud,
Mhm.
from collecting tubules up to the bladder.
Very good. And collecting tube, from the collecting ducts up to the ureter. Okay. And which portion is developed from the metanephric mesenchyme?
All the glomerulus up to collecting duct,
From the
collecting tubules.
glomerulus to the collecting duct. Okay, very good. Thank you so much for participating. Can we ask the next question to Dr. Maheshwari?
Yes.
Okay, would you be kind enough to tell us what would happen if there is failure of the ureteric bud to interact with the metanephric mesenchyme? What's the term? Failure.
Unilateral renal agenesis.
Very good. What if there is abnormal interaction? What would happen then?
Multicystic dysplastic kidney.
Very good. Okay, and all the other problems. Okay, I hear you turning your pages. Okay, please do
No,
not
no,
turn your page.
no.
Okay, I trust you. Okay, no problem. Let's move on. The next question which I want to go to is next question that I want to go to is if you have if you have a ureteric bud which um, differentiates into two ureteric buds before it reaches the metanephric mesenchyme, what is the scientific, I mean, what is the pathological name of this condition?
Duplex collecting system.
Very good. Next one is, what is the most important cause of young infant bladder outlet obstruction in males?
Persistence of posterior urethral valve or membrane.
Very good. Okay, thank you so much for participating. Can we
Thank
ask
you.
the next student, that is Dr. Mohammed, our new
Yes,
student?
doctor.
Thank you so much for participating, Dr. Mohammed. Our question to you is, Our question to you is, if you have to take one kidney for renal transplantation, which kidney will you take, the left or the right?
Left one because it have a bigger
Renal vein.
vein.
It has a longer renal
Yes.
vein. Thank you so much. That's the right answer. Next one is, if I have to tell you that if I have to tell you that you have a patient and on incidental finding, you see that the patient's kidney is lower than the lumbar to vertebra, which artery is responsible for this problem?
IMA, inferior mesenteric artery, sir.
Oh, okay, very good. Very good answer. Next one is, if I have to ask you that what are the three portions or three segments at which the ureter is obstructed? Obstruction of the ureter.
Okay, there is the
Number one.
closest the urethral pelvic junction,
Very
then
good.
the pelvic,
Pelvic inlet and
then
pelvic
the
inlet.
then the utero
The
uterovesical
last
junction.
one is in the uterovesical
Vesical,
junction.
yes.
Okay, very good. Absolutely amazing. The next one is, if I have to ask you, okay, let me see if we have any other student. Okay, no others. Okay, we also have Dr. Naud who wants to participate. So thank you, Dr. Mohammed, for participating. Every answer you gave was correct.
Thank you, doctor. Thank you.
Can we ask the next question to our friend, Dr. Naud, to see if he's there? Dr. Naud, are you willing to participate? Yes or no? Okay, I guess not. Okay, no problem. My next question was, what are the blood supplies of the ureter? Okay, I'm pretty sure I have just discussed it, so you guys can say it out loud. Okay, no problem. Now, the thing is, from what it looks like, is that you guys have understood the embryology and the anatomy of the renal system. Before we jump into the physiology, do you guys want to take a break or continue forwards? Okay, how long do you guys want to take that break? Okay, 15 minutes is too long. Okay, so we're gonna stick to 10 minutes. Okay, 10 minutes then. Okay, 10 to 12 minutes, that's what we're going to do. And then we're going to come back in 10 minutes. Okay, thank you. Okay, is everyone back from the break? Okay, perfect. So what do you guys do during your 10 minutes break during the lectures? Do you guys have something to eat or drink or coffee? You sleep in for 10 minutes? Okay, that is very, very good. Okay. You can sleep for 10 minutes whenever you want to. That is very good quality. Okay, so you can sleep. Okay, good. Listen to music, stretch, coffee. Okay, good. Very good. Okay. So having said that, let's start with our renal physiology. Is everyone ready to begin? Is everyone ready to begin? Okay, perfect. Okay, so let's start. So with renal physiology, what we are going to do is we are going to talk about the body compartments. Okay, we are going to talk about the body compartments. And before we talk about the body compartments, okay, we're going to talk about the different types of fluids that are there, and you guys will help me out. Okay, you guys will help me out. First of all, if the body mass of this patient over here is 70 kilograms, please do not look at the book. This is something which you guys should be able to answer from your basic medical knowledge. Can we have you guys unmute yourselves and tell me the answer, please? Okay, so how much of our body is water? The total body water? Wo-
60%.
Around 60%, 60 to 70%.
60% of our body is water. So 60% more or less of this patient over here. Okay. So 60% of this patient over here is water. So let's say 60% of the 70 kilogram is roughly around 42. Okay. Or exactly 42. And the rest is non-water mass. Okay. So the rest is non-water mass. So 28. So 60% is water and 40% is not water. Okay, good. My next question is, out of out of the 60% of water, okay, out of the 60% of water, how much is extracellular fluid and how much is intracellular fluid?
20
Two-thirds is intracellular.
Okay.
40% is extra. Oh, sorry.
Third extracellular.
And 40% is
Okay, two-third
two-third.
is intracellular, that is ICF.
And one-third is
One-third is
extra.
Interstitial.
Extracellular.
ECF. Okay, okay, good. If we have to divide ECF, ECF can be divided into plasma fluid and ECF can be divided into interstitial fluid. Now, before jumping into that, so if two-thirds of 70 kilograms, so that's around for two-thirds of 70
28.
roughly around
28.
28, and the rest is 14. Okay, out of here, ECF, how much is the interstitial fluid and how much is the plasma fluid?
The
Two-thirds
plasma
is
fluid is three
interstitial.
liters.
Okay, so basically, out of the 100% of ECF, 75% is interstitial fluid, 75% interstitial fluid, meaning the fluid that stays in the interstitium. Okay, and the rest of the 25% is plasma fluid. Okay, so if 25% of 14 kilogram, 14
Three and a half.
that's 3.5, and 75% is around 10.5. So that's that. And the question is, how much of the how much of the intracellular fluid is RBC volume? How much of the intracellular fluid is RBC volume?
2/3 is 28.
I didn't get the question.
The question.
How much is the RBC volume? What is the volume of RBC?
Yeah, 40%.
40% is
40%.
okay. So basically, the 40% is not the 40% is intracellular fluid. Not all of the intracellular fluid is basically RBC. Okay, so the RBC volume should be close to around 2.8. Okay, should be close to around 2.8 liters. Okay, next one. And then another question is if we take blood in a tube, okay, if you take blood in a tube, this part over here is the deposited segment, and this part over here is the non-deposited segment. Okay, now right now, if I have to ask you which portion of this represents the hematocrit, A or B?
B.
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 Hema-
B.
B.
It's supernatant.
Mm-hmm.
B.
So
A.
B represents the hematocrit. Okay, that's that. Okay, now we can go back to our text. And our text says that high kinin or high hykin. Okay, hykin is basically high potassium intracellularly. So intracellular fluid, it contains a lot of potassium. Okay, so first of all, thank you so much for participating, and that's that. So the intracellular fluid, it contains a high amount of potassium, and we have to go by the 60-40-20 rule. 60-40-20 meaning that 60% of total is total body water. Out of this, 40% is ICF, 20% is ECF. Out of ICF, hykin, meaning the potassium is more, mainly composed of potassium, and ECF, the sodium is more. Okay, so the sodium stays more. So sodium chloride and bicarbonate, and potassium, magnesium, and organic phosphorus. Out of here, potassium and sodium is more tested on. So that's that. Okay, can anyone tell me very quick the serum sodium level and the serum potassium level? Very quick.
Serum
What is-
sodium 135 to 145, potassium 3.5 to 5.5.
1.5 to 4.
Very good. Okay, so that's that. Everyone should know that when you guys are going through your patients in the wards, and if you guys see abnormal count, you guys will not have enough time to go and check whether it's in the normal range if you do not know the normal range, because hyponatremia and hypokalemia can be life-threatening. Okay,
Repeat, please, the normal range. Repeat, please.
sodium is 135 to 145, potassium is 3.5 to 5 or 3.5 to highest we can go to is 5.5. Okay, so that's that. Plasma volume can be measured by radio labeling albumin. Okay, by radio labeling the albumin, because the plasma contains a high amount of plasma protein. The most important plasma protein is albumin. If you want to understand how much plasma volume a patient has, we have to let the patient have radio labeled albumin, and then by measuring the label of the albumin in the patient, we can measure the plasma volume. Okay, that's that. Extracellular volume can be measured by inulin or mannitol. Okay, these measurements by different types of substances are very, very important. So once again, plasma volume can be measured by radio labeled albumin. Extracellular fluid can be measured by inulin or mannitol. Okay, next one is serum osmolarity. Serum osmolarity. What is the serum osmolarity? Serum osmolarity is basically 285 to 295 milliosmol per kg per water. It's important that we keep the serum osmolarity in this range, because hyper and hypoosmolar fluid both can cause cellular damage. Hyperosmolar fluid can cause cellular shrinkage. Hypoosmolar fluid can cause cellular swelling, both of which will cause cellular damage. So normal range is 285 to 295. Next one is plasma volume. If you want to calculate plasma volume, how do we do that? There's another way. Either we can measure it by radio labeling albumin, or we can do a calculation that is total body volume into 1 minus hematocrit, And the thing is, this equation over here compared to all the other equations, this is not very high yield. You will not receive a lot of questions regarding this equation because this is not how they want to test the plasma volume level. But even if they do, just try to see if you can remember this. If you can, this should not be a problem. Okay, good. Next one. Next one I want to go on to is the glomerular filtration barrier. This is responsible for the filtration of the plasma according to the size and charge of and selectivity. So not everything can be purely filtered. There has to be charge and there has to be a size for which the substance can be filtered. So before all of that, let's talk about the filtration barrier. So the first thing is the fenestrated capillary endothelium. Okay, before we do that, can we talk about the barriers of the brain? Okay, what are the blood-brain barriers? What are the components? Can I get some fast answers, please? Fast answers on the blood-brain barrier. Anyone?
Basal lamina,
Astrocyte membrane.
the basal membrane of endothelium, then endothelium, then astrocyte feet.
And
3 components, I said.
did you say fenestrated capillary endothelium?
In brain, no, I didn't.
In the brain.
Non-fenestrated.
Non-fenestrated.
No, not fenestrated.
Very good. Yes. In the brain, it's non-fenestrated. Okay. Very good. And over here, okay, so thank you so much. Over here, what we have is the fenestrated capillary endothelium. So fenestration in the brain, there's no fenestration. Over here, we have is the fenestrated capillary endothelium. Fenestrated capillary endothelium is important for maintaining the proper structures through which filtration can occur properly. Next one is the basement membrane. The basement membrane contains type 4 collagen. This is very important. Type 4 collagen. Can you guys name a pathology in which there is formation of antibodies against the basement?
Good
Posture.
Good
Good. Okay. Next one. Next one is visceral epithelial layer consisting of porocyte foot processes. Visceral epithelial layer consisting of porocyte food processes. Okay, so fenestrated capillary endothelium, basement membrane with type 4 collagen, and visceral epithelium consisting of the porocyte food processes. These are the 3 things that are responsible for forming the glomerular basement membrane. Charge barrier, all 3 layers are negatively charged. Okay, they are negatively charged. So if they are negatively charged, can negative components pass through? Can negative components pass through? Okay.
No.
No. Good. Okay. 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 Let's talk a little bit about Goodpasture syndrome and let's talk a little bit about Alport syndrome. Let's talk about these 2 things. First of all, which type of in which disease is antibodies formed against the basal membrane of the glomerulus?
Goodpastures.
And
Alport.
Goods
Okay.
pastor, as we say.
Alport syndrome is not an
And-
antibody-related disease of the basement membrane. It is a defect of the type 4 collagen.
Yeah.
If we have a defect of the type 4 collagen and the basement membrane is not formed properly, what other structure is also not formed in Alport syndrome? What are the conditions in which which 2 structures are hampered as a result of Alport syndrome? One is the basement membrane. Which
Lung
one
and
is it?
kidney.
Ears. Very good.
Hearing problem.
Eyes, ears. Okay, good. So all the places where the type 4 collagen is in. Okay, if we have to talk about if you have to talk about the collagens very, very quickly, okay? Okay. The collagens, type 1. 1 for ONE, meaning bone. Okay. 1, bone. Bones have type 1. 2,
Cartilage.
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 Very good. Okay. Cartilage. Okay. 4. Everything under the floor. Everything under the floor, meaning all types of basement membranes. And type 3 is everything else for the rest. Okay, type 3 is all the rest. So that's what we're going to do. We're going to discuss this in details in biochemistry. but that's that. Okay, so if we have a defective type 4 collagen, then not only will the basal membrane in the Alport syndrome be affected, there will the all the other structures which contain the type 4 collagen, they will also be affected. I asked about the disease where antibodies are formed against the basal membrane, and that disease for the glomerulus is Goodpasture syndrome. Okay, next one is size barrier. So what I was talking about, you need a certain type of charge and you need a certain type of size in order to pass through the glomerular basal membrane. So first of all, if the substance is negatively charged, the negatively charged will get repelled. It will not pass easily. So for example, albumins will not pass easily, and the size has to be a certain size. So fenestrated capillary endothelium will prevent the entry of any substance which is more than 100 nanometer. Okay, they will prevent the entry of substance which are anything above 100 nanometer. The podocyte food processes and the slit diaphragm will prevent the entry of the molecules anything above 70 to 60. Above above 70 to, 50 to 60. Okay, so any any size of the substance which is above 50 to 60 will not be able to pass through the slit diaphragm, and any size above 100 will not be able to pass through the fenestrated capillary endothelium. These things are not that high yield. You will not be tested on this as much, but just to realize that they have a certain size, just try to remember the word 100. So 0 to 100 should be acceptable. Above this, no substance should pass through. If I tell you that a substance is passing through that is above 100 and the charge is also negative, then you have to understand that the basal membrane is compromised. The basal membrane is not working properly. Okay, are we clear on this? Yes or no? Okay, good. Okay, you had a really weird UL question on this sizing. Okay, would you mind sharing the question with us, Dr. Would you mind sharing the question with us? What was the question you received from the sizing of the substances? Exactly. So that's the thing. Okay. So anything above more than 100 should not pass through. That's the only thing that you have to understand. Okay. Next one. Next one is we have to understand is renal clearance. Okay. So clearance. What is renal clearance? Clearance is basically the volume of plasma from which the substance is completely cleared in the urine per unit time. Okay, renal clearance. This is a very basic knowledge of medicine. I'm pretty sure we all know what this is. So basically the amount, so basically we have the plasma. Okay, then let's say we have another substance over here. Okay, let's say we have another substance over here, and that substance can be renally cleared away. That substance can be renally cleared away. And now the question is renal clearance. What is the clearance of this substance? The clearance of the substance is basically the volume of the plasma. So the clearance, it represents the volume of the plasma from which the substance is completely cleared in urine per unit time. Okay. And now they have a very high yield equation for this. That is the equation that is C is equals to UV by P. Okay, so C equals to UV by P, where C stands for clearance of the substance. Let's say there's a drug. Then how can we measure the clearance of that drug? Let's say if there's a urine concentration, we measure the concentration of the drug in the urine. Okay, then after that, we have to measure the plasma concentration of that drug. And if we can also measure the urine flow rate, that is the amount of urine that is being let out per minute in milliliters, then we can easily put all of these numbers in this equation, and we can get an estimate of the clearance, that how much of that drug is being cleared from the plasma. That's that. Right now, let's say if the clearance is less than the GFR, okay, so the normal GFR of the body is 180 liters per day or 125 milliliters per minute. Okay, if the clearance is less than the GFR, then obviously then it's being cleared less, meaning it's being let out less. So there's more absorption in the kidney. So there is, as a result, net tubular reabsorption. So there is being tubular reabsorption. If the clearance is more than the GFR, that is 125 milliliter per minute, If the clearance is more than that, then that means that the kidney is actively secreting that substance. Okay, this is very easy to understand what's going on. And if the clearance is equal to the GFR, that means that there is no absorption, nor is there any secretion. So no reabsorption or no net secretion. Okay, very easy to understand what's going on. Okay, next one. Next one is GFR. How do we calculate GFR? First of all, the GFR we can calculate is by two methods. First of all, we can infuse the patient with inulin, and then we can measure the clearance of inulin. Why do we use inulin to measure GFR? Because inulin is a completely freely filtered substance. It is neither reabsorbed nor it is secreted. Okay, so inulin is not hampered with it. No, we can't absorb inulin, nor can we secrete inulin. It leaves the body as smoothly as it enters the body. So it's an excellent measurement of the body's GFR. So once again, if we have to measure inulin clearance rate, so clearance should be measured by the urine concentration of inulin into the urinary flow rate divided by the plasma concentration of the inulin. The plasma concentration of the inulin. That's that. This is one way how we can calculate GFR. Another way is by measuring the different types of pressure. Okay, measuring the hydrostatic pressure in the glomerular capsule or the Bowman space, subtracted by the plasma osmolarity pressure in the glomerular capsule and the Bowman space. Okay, so that we are going to discuss about this equation in details in the future. So do not worry. Okay, I just want to get you guys acquainted with this equation if you're already not acquainted with it. But we will discuss this equation in details. Okay, the normal GFR is 100 milliliter per minute or 125 milliliter per minute. Okay, it varies book by book. For first aid, it's 100. For the other books of medicine, it's 125. But overall, it should not be less than 100 or more than 125. So that's the acceptable range. If it's 100 milliliter per minute, and then the total amount of GFR in a whole day is 180 liters per day, 180 liters per day. So that's how much your kidney works throughout the whole day, is that it helps clear 180 liters of fluid. Okay, the creatine clearance is also an approximate measure, but if someone has a muscular breakdown, then obviously they will have more creatinine, and that can overestimate your GFR. Okay, so creatinine clearance, because creatinine is also not hampered with, that is, it's hard to be reabsorbed, nor it is secreted properly. So, but since creatinine is an important metabolic waste product of muscular breakdown. Okay, if there is more muscle breakdown in a patient, and if you estimate the GFR of that patient, they will overestimate the GFR because the muscle is being broken down. Okay, so that's that. This is just a diagram to show that how plasma creatinine level decreases as GFR increases. So that's that. Okay, so the graph kind of goes like this. Not a very high yield graph. Okay. Okay, next one. Next one is effective renal plasma flow. Effective renal plasma flow. How do you measure the plasma flow? We measure the effective renal plasma flow by using a substance called para-aminohippuric acid. Para-aminohippuric acid. Para-aminohippuric acid clearance is used to measure the plasma flow. Between filtration and secretion, there is nearly 100% excretion of all para-aminohippuric acid. Okay, so right now, if I have to ask you, okay, if I have to ask you, you are at liberty to unmute yourself and answer me this so that I don't have to go back to the chat box. My question to you is, okay, so if I have to ask you one, my question to you is, what is the substance that is used to measure the plasma volume? Can I get some answers? Plasma volume. Again, I hear someone going back at the pages. Okay.
Albumin.
You're labeling.
Okay, please refrain from going back to the pages. If you do not remember, you do not remember. As simple as that. Okay.
Radio label.
Albumin.
Radio labeled albumin. Very good. Okay. How do you measure the creatinine I mean the GFR in a normal person.
Inulin.
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 Urine. Okay, very good. How do you measure the extracellular fluid volume?
Extracellular.
Mannitol.
Potas.
Mannitol or inulin? How do you measure effective renal plasma flow?
PAH.
PAH,
Uric
Amino hippuric acid. Okay, very good.
pure acid.
These are the things. If needed, okay, just for a quick revision, you have this space over here. Just write these things down so that for a quick revision, all you have to do is just look at the small notes over here and that which substances are required to measure which volume or which thing, and this will really help you out. Okay, so do that. Thank you so much for your participation. Okay, good. Okay. Next one is effective renal plasma flow. How do you measure? So once again, you measure the creatine. So once again, you measure the clearance of the para-aminohippuric acid, and this will give you an estimate of the renal plasma flow. That's how you measure the renal plasma flow. Okay. Now we'll talk about the renal blood flow. Okay. The renal blood flow is basically the renal plasma flow. Okay. Renal blood flow is basically the plasma flow. Renal plasma flow divided by 1 minus hepato 1 minus hematocrit 1 minus hematocrit. Okay, and this is a very important equation. Okay, this is a very important equation. This is something which you have to understand, and that's that. So usually the 20 to 25% of the cardiac output is basically your renal blood flow. Okay, it's basically your renal blood flow, and the renal blood flow is measured by renal plasma flow divided by 1 minus hematocrit. Okay, okay. Before we move on to this one, okay, I want to talk to you guys about something that is during your actual USMLE step 1 exam. Okay, during your actual USMLE step 1 exam, what you have is you have 15 minutes of tutorial. Okay, you have a 15 minutes of tutorial. So the thing is, the tutorial is not that high yield because you know most of the tutorials, because the UWorld prepares you for the actual exam by using the same type of format that is used in the actual exam. So UWorld will prepare you accordingly. So there's nothing new about how to answer the questions, what to do. So you guys already know that. So in those 15 minutes, what you guys should do is, if you look at the end of first aid, you have an equation. You have an equation page where the first aid contains all the equations for different types of topics, including biostats, and all the equations are over there. Okay. So what I would advise you guys to do is I would advise you guys to practice those equations from time to time, so that in those span of 15 minutes, you can use 5 to 6 minutes to write down all those equations from your memory into the rough paper, which will be given to you. So what would happen is this will allow you to answer the questions regarding this will allow you to answer the questions regarding the equations. Okay. So that's that. Okay. So having said that, let's move forward. Let's move forward. The next one is filtration. Okay, so what I want to talk about is filtration. Filtration is basically how much filtration is basically measured by filtration fraction. That is how much of the substance is basically how much of the GFR is basically filtered. Okay, how much of the renal plasma flow has the GFR been filtered? So we measured filtration fractions by GFR by GFR by renal plasma flow. GFR divided by renal plasma flow. How much of the renal plasma flow is basically filtered off? Okay, so that's that. The normal filtration fraction is 20%. Okay, then the equation for the filtration fraction is very important. The normal filtration fraction is 20%, and the filtered load is basically the GFR into the plasma concentration of that substance. This is something which is very easy to understand, that filtered load, meaning that the load or the amount of the filtration which contains the substance that is being filtered off, is basically the GFR into the plasma concentration. So that's that. Once again, the GFR can be estimated with creatine clearance, renal plasma flow with PAH, and that's what we can, that's what we have already studied. Okay, next one. Next one, what we want to go to is which the substances that can cause dilatation of the efferent arteriole and the substance that can cause constriction of the efferent arteriole. Okay, so basically PDA, meaning that prostaglandins dilate efferent arteriole. Okay, so if there is an increased release of prostaglandins, they can dilate the efferent arteriole. And once again, be at liberty to unmute yourself and answer me this question. If we have dilatation, if we have a condition in which there's extreme amount of prostaglandin being released and there's dilatation of the efferent arteriole, will the filtration, will this allow for more blood to be filtered or less blood to be filtered?
More.
More.
More blood to be filtered. Okay. Now, my next question is, if we have a patient who is taking NSAID, will he have efferent arteriolar constriction or efferent arteriolar dilatation?
Constriction.
Constriction.
Efferent
Constriction.
arteriolar constriction. Okay. My next question is, angiotensin 2 is used to constrict efferent. Okay. Angiotensin 2 is used to constrict efferent. And angiotensin 2, if it constricts efferent arteriole, now what will happen to the filtration fraction? Will it increase or decrease?
Increase.
Increase.
Okay.
Increase. Increase.
Increase.
Increase.
Increase.
And
Increase.
if we use an angiotensin converting enzyme, okay, if we use an angiotensin converting enzyme, ACE inhibitors, okay, ACE inhibitors, angiotensin converting enzyme inhibitors such as ramipril or lisinopril, will there be more angiotensin or less angiotensin?
Less angiotensin.
Less.
Okay, so if there is less angiotensin,
Less filtration.
there will be more filtration or less filtration?
Less.
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 There will be more filtration with ACE inhibitors
There we go. Yes, there will be more.
because it spends longer
More.
in the glomeruli.
Okay. My next question is, if there is a patient with diabetes, okay,
But doctor, we said if there is
one
angiotensin
second,
2 constricts efferent
Give me-
arteriole, so it increase.
okay,
Now
one
there is
second,
no,
just-
no angiotensin, it will decrease.
okay, just let me explain the whole thing. Just give me 1 second. First and foremost, angiotensin 2 will constrict the efferent. If we use an angiotensin converting enzyme inhibitor, okay, angiotensin converting enzyme will convert angiotensin. So what is the function of angiotensin converting enzyme?
It convert 1 to 2.
Convert angiotensin 1 to 2.
If we prevent that enzyme, will there be more angiotensin or less angiotensin?
Less. Less
If we have
angiotensin
Less
too.
angiotensin 2.
Too.
If we have less angiotensin 2, will there be more constriction or less constriction?
Less
Less
constriction on the efferent.
Okay, now this is the question. In diabetes, do you have hyperfiltration damage of the kidney due to non-enzymatic glycation of the vessels? Yes or no?
Yes.
Okay.
Yes.
In those patients, if we use angiotensin converting enzyme inhibitors, will they help protect the kidney from hyperfiltration damage? Yes or no?
Yes.
How? And now this is the question: how? How will they do that?
Repeat the question, please.
In diabetic mellitus, there is non-enzymatic glycation of the afferent and efferent arterioles, and there's hyperfiltration damage as a result of non-enzymatic glycation. And you guys have said that using ACE inhibitors will help prevent the hyperfiltration damage. And the answer is right. I just want to know how.
Because more blood will pass, will not stop.
If
at
we
the
use
pulmonary.
angiotensin converting enzyme, will this cause efferent arteriolar dilatation or constriction?
Dilatation.
Dilatation.
There will be less time.
Dilatation of the efferent arteriole, will there be hyperfiltration or no hyperfiltration?
No.
Decrease in
Should be
filtration.
less filtration.
No hyperfiltration. If there is low hyperfiltration or no hyperfiltration, will there be more damage or less damage?
Less.
Less
Less.
damage.
Okay. Now do we understand? Are we clear?
Yes. So summary, doctor.
There is in the presentation.
So
Okay.
S inhibitors decrease the filtration, GFR. Yes?
Yes.
Summary.
Okay, but it depends on all the situations. This is dependable. Okay, basically ACE inhibitors will decrease angiotensin 2, and if angiotensin 2 decreases, then there will be dilatation of the efferent arteriole. Now, this can increase or decrease the filtration based on different types of situations. If there is complete occlusion, if there is complete occlusion of the efferent arteriole, then further constriction of the efferent arteriole will only damage the kidney. In that case, using ACE inhibitors can cause increased filtration. Okay. For example, in case of diabetes, okay, as a matter of fact, at one point, the patients get diagnosed with chronic kidney disease because there is low GFR, and that's because there is extreme constriction of the efferent arteriole by non-enzymatic glycation. So in those patients, using ACE inhibitors is actually protective. Okay, it's renal protective, meaning that it will protect the renal from hyperfiltration damage. Okay, but in a patient who has dilated efferent arterioles already, if you use ACE inhibitors, there will be further dilatation of the efferent arterioles, and as a result, the filtration will decrease. So GFR will also decrease then. So to be honest, it all depends on the dilatation of the efferent arteriole and the condition at which we are going to prescribe the medicine. But
So in both situation, the GFR will decrease, but it depends in which situation we want it to decrease or increase. So we use the ACE.
GFR can increase or GFR can decrease based on which situation. For example, so once again,
Yeah.
let me explain. In diabetes, if you have complete occlusion of the efferent arteriole, do you have increased GFR or no GFR?
Increase GFR.
Increase GFR.
Increase GFR initially, but so what if if it's happening for a long period of time? Then
Will be taken.
at one point, will the GFR decrease or not?
Of course. With
Of course,
time.
the GFR will decrease at one point, then the kidney will go through different stages of CKD 1, 2, 3, 4, 5. We have 5 stages of CKD. So depending on which stage the kidney is in, the GFR will decrease. But if we use ACE inhibitors, can we prevent the progression of CKD by increasing the GFR? Because
Yes. No,
Yes.
now do you understand?
Yes.
No? Okay, perfect. Are we all on the same page over here?
We also have to think about the time that has gone, not only
Yes.
right now.
Yes.
Okay.
So the best thing that you have to do is remember PDA, okay, and ACE. If you guys can remember that angiotensin 2 constricts efferent and prostaglandin dilates afferent, no matter what situation you are thrown at, you guys will be able to answer the question with excellence. Okay, now let me unmute you and ask you, are we all on the same page? Okay. Okay, you're confused. Okay. So the thing is, let's clear this confusion further when we reach the pathology. Okay. How about for now you understand that prostaglandin dilates the efferent and angiotensin 2 constricts the efferent? Yes, there was a very important NBME question on my discussion right now. Very good, Dr. Nikki. So you have been doing the questions really well. Okay, voice is mixed up. Okay. All I want to ask you is, have you understood that prostaglandin dilates the efferent and angiotensin 2 constricts the efferent? Have you understood this? Okay. If you understood up to this, then it was my mistake to ask you a very complicated question. So what will happen is eventually as we move forward, the pathology section will clear away your confusion if you can just understand the physiology right now. Okay, so if you understand that PDA and ACE, that's enough for now. And in the future, you will understand what I'm talking about when we start talking about diabetic nephropathy. Are we clear? Are we all on the same page now? Okay. Okay, perfect. Okay, let's move forward. Okay. Right. Okay. Now what I have to do is I have to.
Doctor, just one question.
Yes,
RPF and PAH, what they stand for?
RPF is renal plasma flow. PAH is para amino hippuric acid.
Thank you.
You are welcome. Okay. So this is what we're going to do. What we're going to do is, okay, this is what we're going to do. What we're going to do is we are going to talk about the filtrations. Okay, we're going to talk about the filtration. So let's say that this is the glomerular filtration barrier. Okay, let's say that this is the glomerular filtration barrier. Over here, what we have is the Bowman space. Over here, we have the glomerular capillaries. Okay, so, okay, I would need the help of you guys over here. Not every one of you, because this causes a voice mix-up, and I can't understand who's talking what. Okay, so I need the help of two physicians who can help me out. Can anyone help me out with this pressure graph over here? Can anyone help me out? Who are the two physicians who can help me out? Can we ask Dr. Can we ask Dr. Tareen and Dr. Hussam over here to help me out with this? Okay, so two students for now.
Yes, doctor, no problem.
Two more people. Okay, so that's what's going on. Okay, so first of all, over here, Dr. Hussam and Dr. Tareen. So all I want to know from you guys is how the fluid is being passed, either from here to here or from here to here. That's all I want to know, nothing else. Okay, so if you have a hydrostatic pressure of over here, okay, the first question goes to Dr. Tareen. Okay, which way will the fluid pass from A?
From GC to BS.
Okay, so basically from A to B. So the fluid will pass from A to B. So if I ask you right now, Dr. Tarin, that you have a high amount of hydrostatic pressure in the GC, will this cause more flow or less flow?
More flow
Obviously more
down
flow.
to the Bowman space.
Right, A to B. So more flow from A to B. Okay. And if I tell you, and if I ask you, Dr. Hussam, that you have a high amount of plasma uh, um, plasma oncotic pressure over here in the GC, what is the path flow? What is the path flow of the fluid from A to B or from B to A?
From B to A.
Very good. And vice versa. High amount of the plasma oncotic pressure in A will pull the fluid from B to A. Okay. So guys, basically what's happening over here is this is basically a very basic scientific knowledge, science knowledge. That is the knowledge of osmosis. Osmosis is basically the movement of free water from its concentration of a high solute to a less solute condition. So basically from over here to over here, meaning that if there's a high hydrostatic pressure, the fluid will move to this side. If there's a high oncotic pressure, they will pull the fluid to the opposite side. Vice versa, over here, what we have is if we have a high hydrostatic pressure, once again, Dr. Tarin, hydrostatic pressure is high in the Bowman space. Which way will the fluid go to now? B to A or from A to B?
B to A.
Yes, B to A. Very good. So very easy to understand. Nothing complicated over here. And if we have a high amount of oncotic pressure over here, Dr. Hussam, which way will the fluid go?
A to B.
A to B. Okay. Now, GFR, if we have to calculate GFR, okay, now we will calculate GFR. So basically, GFR, the net movement of fluid. Dr. Tari, this question is for you. GFR, the net movement of fluid is from A to B or from B to A?
A to B.
A to B, very good. Okay, in order for us to calculate this, first of all, Dr. Hussam, if we have to calculate from A to B, okay, what are the pressures that are working on the same side? Same side? Which pressures
Yeah,
are
the osmotic pressure inside the vessel and the oncotic pressure out of vessel.
okay?
In the B side.
If we have to subtract, can we subtract this one from this one? Yes or no?
Yes. So the two down arrows, you add them and then minus the two up arrows.
Exactly. Okay, so the two down arrows, we add them. Okay, so P Okay, let me just use the color which I used. Okay, so P, G, C, this one and this one, they're all going the same way. Okay, so we add them plus BS. Okay, I'm sorry, I should have used the violet one. Just getting a bit annoyed over here. The changes in colors. Okay, so I'm pretty sure you guys understand. Next one is Dr. Hussam. Which are the next two pressures I have to add? Next two pressures which I have to add.
The up arrows.
All right, this one and this one, right?
Yes.
Okay, so minus P B S plus this one. Okay, okay, G C. And if we can do that, we can have a measurement of the net filtration pressure, or even you can also calculate GFR like this, to be honest. So net filtration pressure. Okay, net filtration pressure. Okay, now. Okay, now my next question is, okay, so let me at first thank Dr. Hussam and Dr. Tarian for helping me out. Thank you so much, guys. Has everyone understood what we have just discussed? Has everyone understood what we just discussed? Very easy. It's just a mathematical situation going over here. Okay. Okay, if you have not understood, I would be more than happy to make you understand it once again. First of all, this is the glomerular basement membrane. This is the part above, the part below. The GFR is basically the filtration from here to here. There are different, what's happening is fluid is going through this way. This fluid has a certain hydrostatic pressure and a certain plasma oncotic pressure. And the fluid being filtered also has a certain hydrostatic pressure and a certain oncotic pressure. Okay, so the hydrostatic pressure of this part will try to push the fluid from here to here. And the oncotic pressure, usually what oncotic pressures do is that they try to absorb fluid because they're solutes. Okay, so oncotic pressure will try to absorb the fluid from here to here. And the pressure in this part, that is the filtered fluid, also has a hydrostatic pressure pushing the fluid out and the oncotic pressure pushing the fluid in. So if we have to calculate the net pressure movement, the net pressure is basically the pressure which is needed to cause the GFR. GFR is the glomerular filtration, GFR, okay, glomerular filtration pressure, glomerular filtration rate. Okay, so the net GFR is basically from A to B. This is the movement pressure that we need to calculate. In order to calculate this, after we have drawn this out, all we have to do is add the pressures going in the same way, that is these two, and subtract this value from the pressures going in the opposite way. If we do that, we get a net filtration pressure through which the fluid is being moved from A to B. Okay. Is it clear now? Should be very clear. Should be very clear. Okay. If not, I'd be more than happy to explain it again. The only difference is I'll do it at the end of the lecture. Okay. Okay. Perfect. Okay. Now what? Now the thing is, if everyone has understood this, then there's another very high yield thing that we have to understand. Okay. That we have to understand. And for this one, I will need the help of two more students at random. Okay, random students. So first of all, is anyone interested? Okay, so we have Dr. Mohammed, and is there anyone else? Is there anyone else? Can we ask Dr.
Yeah, me.
Okay, who is me? Me is
Iman.
Dr. Iman. Okay, good. Okay, perfect. Thank you so much, Dr. Mohammed and Dr. Iman, for helping us out. Okay. First of all, what we are going to ask you is, this question goes to Dr. Mohammed. Okay, Dr. Mohammed, what is the equation for the filtration fraction?
GFR on RPF.
Very good. GFR on RPF. Okay. Now the next question goes to Dr. Iman. If I ask you that you have increased GFR, what will happen to filtration fraction? Will it increase or decrease?
Increased.
Increase. Very good. GFR will increase. Filtration fraction will increase. If I tell you you have, okay, right now the GFR is not increased, RPF is increased. What will happen to filtration fraction?
Decreased.
Okay, filtration fraction will decrease. Okay, very good. Okay, so basically this is the basic knowledge which we need in order to answer all the different types of changes that are occurring in GFR, renal plasma flow, and filtration fraction. Okay, and the changes that are occurring over here. Okay, so I'm going to ask you one by one. Before I do that, let me just draw the glomerulus. This is the pathway. Okay, okay. First condition. The first one goes to Dr. Mohammed. Okay, efferent arteriolar constriction. Okay, wait for a minute. I'll ask you what the problem is. Okay, so this is the efferent, this is the efferent. Okay, efferent, basically this way, efferent, efferent. Okay, so right now, if you have efferent arteriolar constriction, efferent arteriolar constriction, will there be more renal plasma flow or less renal plasma flow?
In
That
the
is
afferent, less renal plasma flow.
okay. If there is less renal plasma flow, okay, so this is one, this is one done. Next one is, if you have efferent arteriolar constriction, will there be more GFR or less GFR? Will there be more filtration or less filtration?
Less.
Less filtration. So as a matter of fact, what will happen is GFR and renal plasma flow will both decrease at the same time. So as a result, they will decrease equally. Equal, if they are decreased equally, will there be a change in filtration fraction? Yes or no? Or will
No, the same. The same.
remain the same? So this is what happens in efferent arteriolar constriction. Okay, thank you. So this is one. Okay. Next one is okay. Next one is efferent. This one goes to Dr. Iman. If efferent arteriolar constriction. Okay. If we have efferent arteriolar constriction, now this part is constricted. Okay, now this part is constricted. Efferent arteriolar constriction. If this part is constricted, will there be more renal plasma flow or less renal plasma flow?
Yes.
Hmm?
It more. It
No.
the
If
flow.
the plasma, I mean the renal plasma flow of the fluid, will there be more flow or less flow? There's an obstruction over
Yes.
here.
Decrease.
Decrease, right? Very good. Now, if this part is decreased, if there is decrease, will the hydrostatic pressure over here increase?
Yes.
Yes, the hydrostatic pressure over here will increase. If the hydrostatic pressure over here increases, the hydrostatic pressure will increase obviously because there's an obstruction. So fluid is still coming, but it cannot go forward. So they will
Yeah.
accumulate over here, increasing the hydrostatic pressure. If it increases, will there be more GFR or less GFR?
More GFR.
Very good. There will be more GFR. If the GFR is increased and the plasma flow is decreased, what will happen to the filtration fraction? Will it be increased or decreased? This is
Increase.
this is decreased. What will happen to the filtration fraction?
Increase.
Very good. Absolutely amazing. That's what it is. Filtration fraction will increase. Okay. Very good. So, okay, 2 down, 4 to go. Okay. Next one. Next one is if we have, okay, now we will go back to our friend Dr. Mohammed. Okay. 1 second. Okay. Right now, if we have increased plasma protein concentration, okay, so over here, if the plasma protein concentration of this part is increased, okay, what will happen to the GFR? Will the GFR be increased or decreased?
Decreased GFR.
Decreased GFR. Why will the decreased GFR happen? Obviously, because this pressure is more, so they will
Oncotic pressure more.
Exactly right. So GFR will decrease. Okay. If GFR decreases, but the plasma oncotic pressure will not put much, will not be any reason for decreased renal plasma flow, or will it cause decreased renal plasma flow? Will it cause
No,
decrease?
the normal renal plasma flow
Normal renal plasma flow. As a result, if GFR decreases, what will happen to filtration fraction?
will decrease.
GFR decrease, renal plasma
Decrease.
flow is the same. Okay. As a result, filtration fraction will decrease.
Decrease.
Very good. Next question goes to Dr. Iman. Dr. Iman, right now, if I have to ask you that instead of plasma protein being increased, now the plasma protein is decreased, what will happen to the GFR?
Increase.
The plasma protein right now is decreased. What will happen to the GFR?
Increase.
Increase. Very good. Okay, increase. I'm not sure if you said increase for the first time or decrease.
Yeah, it's increase.
You said increase. Okay, then I'm sorry. Okay, increase. Okay, so you said increase. That increase is the absolutely right answer. And the next one is what will there be a change in renal plasma flow?
No.
No change in renal plasma flow.
No
As a result,
change.
what will happen to filtration fraction?
Increase.
Increase. Okay, filtration fraction will increase. Thank you so much. Next one. Next one goes to Dr. Mohammed. Dr. Mohammed, over here, if you have a constriction of the if you have a constriction of the ureter, okay, there's a uretary constriction over here. Okay, if there is a uretary constriction, will this increase the hydrostatic pressure over here in the Bowman's capsule? Yes or no? Will this put
Yes.
more pressure? Yes. If it puts more pressure over here, what will happen to the GFR? Can the
Should
GFR
increase.
can the GFR come properly over here because the hydrostatic
No,
pressure?
no. It will decrease.
Very good. GFR will decrease. GFR will decrease. If GFR decreases,
Because there is a backflow, right?
right, there's a backflow. Very good. So if GFR decreases, will this affect the renal plasma flow?
No.
No effect. Very good. Now, what will happen to the filtration fraction once again?
If the GFR increase, the filtration factor decrease. Same. Decrease.
Very good. Good answer. Very good, Dr. Mohammed. Thank you so much. Last one is for Dr. Iman. Once again. Okay. So we have a patient who is severely dehydrated. Severe dehydration. Okay. So for this one, I'll help you out. So the patient is severely dehydrated. If the patient is severely dehydrated, will the renal plasma, will there be more blood in the patient or less blood in the patient?
Less.
If there is less blood volume, I mean less volume of the fluid, not blood, fluid, will the patient have more renal plasma flow or less renal plasma flow?
Less.
Okay. The problem is the renal plasma flow will fall severely.
Yes.
Severe fall of renal plasma flow. The person is very dehydrated. But the GFR at the same time will also decrease or increase?
Decrease.
The GFR will decrease, but it will not decrease as much as the renal plasma flow will decrease. Okay.
Yeah.
As a result, filtration fraction, now let me help you out.
Increase.
Yes, filtration fraction will increase because although the GFR is decreased, it's not decreased that much, but the renal plasma flow has severely decreased, severe decrease of renal plasma flow. As a result, filtration fraction will increase in dehydration. Okay, filtration fraction will increase in dehydration to maintain proper functioning of the kidney. Okay, perfect. Okay. Having said that, we are done with this important table. How important is this table? This table is very, very important. If anyone is you world actively right now, okay, first of all, let me thank our friends, Dr. Mohammed, Dr. Iman, Dr. Hassam, Dr. Tareen, and all the other people who has understood everything that we have just this. Okay, but this table over here, okay, to anyone who's doing your questions actively, okay, how important do you guys think is this table? How many stars should I put over here? I would have put 10 stars around this whole thing if I had something, or if I was not lazy enough. Okay. Okay. Very important. But although it's very important, it's absolutely very easy. Okay. Very, very easy. Have you guys understood this whole thing? Have you guys understood this whole thing? Why efferent constriction cause increased GFR? Very good question. Okay. Efferent, we have a question from another student. Dr. Hassan. Her question is, why will efferent constriction cause? What happened? 1 second. Okay, let me use another. Okay. One second, please. Okay. So to answer Dr. Hassan's question once again, her question is why will efferent arteriolar constriction cause increase in GFR? Okay. So basically, once again, this is the okay. This is what it is. This is what's happening over here. Now we have the arterial supply. Okay. Now we have the arteriolar supply over here, and this is the efferent. This is the efferent. Okay. And right now, if I tell you that okay, if I tell you that the efferent has constricted, there's efferent arterial constriction. If there's efferent arteriolar constriction, the fluid that was coming this way, the water, the fluid that was coming this way, okay, now it cannot go this way as much, right? Because there is an obstruction over here, obviously. So the fluid or at this part will increase. There will be increased accumulation of fluid in this segment of the artery. If there's increased accumulation of fluid in this segment of the artery, Dr. Hassan, the question is for you. You can use the chat box, no problem. Will there be more hydrostatic pressure in this segment? Yes or no? Hydrostatic pressure, will it increase this segment? More, correct. If there is more hydrostatic pressure in this segment, and we know that the hydrostatic pressure in this segment, if it increases, then will this push the fluid from this part to this part? Yes or no? Yes. If it pushes the fluid more from this part to this part because of increased hydrostatic fluid, will this not increase the GFR, or will this increase the GFR or decrease the GFR? Yes, it will increase the GFR. Okay, so good question. And is the confusion clear now? Are we clear? And constriction of ureter should increase too. Okay, once again, if we have constriction of the ureter now, okay, this is not the ureter, okay, constriction of the ureter, so there will be backflow of water. Okay, right now there is more water here. If there is more water here, can water from this side easily come to this side? Yes, no, Dr. Hassan? No. So will there be more GFR or less GFR? And will the GFR increase or decrease? Okay, you got it. Perfect. Okay. Okay, good. Very good. You are absolutely welcome. Okay, anyone else? Else has any questions? Anyone else has any questions? Renal plasma flow. Renal plasma flow is basically the amount of the volume of blood that is going through the efferent to efferent arteriole that contains the plasma is the renal plasma flow. Can you show it on the diagram? What do you want me to show on the diagram? The renal plasma flow? How do you want me to show it? Okay, so what's going on over here? Okay, efferent arteriole, efferent arteriole. This is basically blood, okay, in blood, or the body volume, okay, or I mean okay, this is basically this
Can you
part.
use the first aid diagram? Like the glomeruli that's already there?
1 second, let me just see which one you're talking about. This one?
Yes, that one.
Use this for what? To explain the renal plasma?
Just like to show where like renal plasma flow is. I was kind of getting confused with that too. I'm not
Okay,
sure why.
wait for a second. You see this pathway for the fluid going through all this part over here, right?
Yes.
This pathway of fluid over here, this contains, obviously this contains blood, RBC and plasma and all the other things, right? Am I correct?
Yep. Yep.
Okay. So the portion of this fluid which contains plasma is the renal plasma volume, and the flow is basically the flow of the fluid. So it's as simple as that. There's
Okay,
nothing.
thank you.
Okay, perfect. You are welcome. Thank you for asking the question. Is it also clear to Dr. Karbasi that what I just mentioned? Karbasi. Okay. Okay, perfect. Okay. Once again, I really appreciate you guys asking so many questions. Okay, please do not hesitate to ask questions as many times as you need. Okay, it's my job to make you understand. So that's that. If only and only if we are devoid of all confusions, shall we move forward? Okay. Are we all on the same page, cleared of confusions, loving renal? Okay, loving the renal system and ready to move forward. Okay, perfect. Okay, perfect. Okay, let's move forward. Okay, well, once again, please make sure that you guys understand this table over here. Okay, next one. Next one is calculation of reabsorption and secretion rate. Okay, calculation of reabsorption and secretion rate. First of all, the filtered load, as I have just mentioned, is how you can measure the filtered load. Is basically the filtered load is GFR into plasma concentration of that substance. That is your filtered load. Excretion rate. Excretion rate is, do you remember when we said C equals to UV by P? C equals to UV by P. Okay, UV over here represents the excretion rate, meaning the urinary concentration of the substance into the urine flow rate. Okay, so UV basically presents the excretion rate. Reabsorption rate, how much, what's the rate at which substance is reabsorbed? Reabsorption rate is basically, okay, filtered minus filtered, subtracted from excreted. Okay, so what's going on over here? Okay, so basically, if this is the structure, if it's fully filtered over here, okay, if it's fully filtered over here, and there are also some substances which are being excreted straight from the body, I mean, from the cells of these structures. Okay, my question is, the substance which are being excreted by the body after excreting something, do you think the body will try to reabsorb the excretion physiologically with the
Yes.
tolerance?
Yes, if it's important, yes.
Oh, good. So the thing is, when it does reabsorb it, okay, the amount of fluid that is reabsorbed, okay, the amount of fluid that is reabsorbed, is it devoid of the substances which are excreted after the reabsorption? Do you understand like what I mean? Okay, once again, let me break it down once again. After excreting and reabsorbing, okay, once again, let me draw this diagram. It's important for you guys to understand this, and I'll try my best to make you understand what's going on, only if my marker works with me. Okay, so it's working. Okay, over here right now, the final fluid. After everything, there is excretion, there is reabsorption, and everything. This fluid over here, okay, does it contain the final excreted materials? Yes or no?
Yes, you mean
Okay,
here in collecting duct, yeah?
right.
Yes,
Does it contain the final excreted materials?
Yes.
yes, yes.
Okay, good.
There is no more, of
Is it
course.
possible for the kidney to reabsorb the excreted materials from here?
No.
No, it's not possible, because how will it be? Because this has reached beyond the reabsorption points. Okay,
It's
so this,
ultimately excretion.
right. So as a result, so if you have to measure reabsorption, then reabsorption, can we say that we can measure reabsorption by subtracting the filtered load? I mean, by subtracting the filtered amount of water minus the excreted amount of substances that were excreted, minus the substances
Yes.
that were
Yeah,
excreted.
exactly.
Okay. Okay. I don't know why my marker has to act like this. It's pissing me off. Okay. Okay. So the filtered minus the excreted. Okay, so that's your reabsorption. So that's all I wanted to make you guys understand. That's all I wanted to make you guys understand. Have you guys understood this small little concept? Have you guys understood the small little concept? If not, please don't hesitate to tell me. I'll explain it again.
So like
Doctor,
what's the
secreted and excreted.
reabsorption rate? Oh, sorry.
Okay,
As
go ahead, Dr. Tarin first.
so the reabsorption rate. So if you were
Mhm.
just to rearrange everything, it would just be px times GFR minus UV. Is
Right,
that what you're going for?
right. That's exactly where I'm.
Okay.
Okay, next question was from Dr. Mohammed, I suppose, right? What was your question? Do we have any? Do
Here,
we?
yeah, it's here written.
Hmm,
Absorption is filtered minus excreted, and secretion rate is excreted minus filtered.
right.
I didn't get it. What about
Oh,
the secretion?
okay, perfect. Thank you. Thank you for letting me know that you did not get it.
Thank you.
I'll explain to you once again. Okay, reabsorption rate. What's going on over here? Reabsorption is basically the, how can you calculate the reabsorption rate? That's basically the amount of fluid that's been filtered. Okay, the amount of fluid that's been filtered, devoid of excretion. Okay, minus excreted, minus the excreted. That will represent your reabsorption rate, meaning that's the amount of reabsorption that has already happened. And after the reabsorption has already happened, the freely filtered fluid that's passing through, that's the reabsorption rate. Secretion rate is what's the rate at which a substance is being secreted. That is excreted minus filtered. For example, if you are actively secreting a substance into this fluid over here, okay, the the secreted rate is basically this excreted fluid, okay, this excreted fluid minus the filtered fluid. So it's just the exact opposite. So if there is more excretion of a substance, obviously it will be more than the filtered amount. So excretion rate minus the filtered rate is equal to the secretion rate. Okay, are we
Thank you
clear?
very much, doctor.
Okay, perfect. Okay, so this is not okay. First and foremost, this is not that high yield for you to use for your US 70 step one exam, but this is extremely, extremely high yield to master the concept. Okay, so it's extremely important that we all understand how reabsorption and tubular secretion is happening. Tubular reabsorption is meaning that when the fluid passes through this channel over here, there are cells which will reabsorb a certain amount of substances, right? For example, the most important reabsorption that is required for the kidney to take place is sodium reabsorption. Okay, so if we have to measure the sodium reabsorption, that is basically the filtered sodium minus the excreted sodium. And secretion rate is, so let's say for some bizarre reason, the kidney is now secreting sodium. This never happens, by the way. Okay, but for some reason, let's say for the purpose of understanding this, that the kidney is for some reason secreting sodium. So the secretion rate will be obviously more, meaning that the more sodium will be excreted. So we can simply measure secretion rate by excretion minus the filtered. Are we clear on this? Are we clear on this? Okay. Okay. Please don't let this confuse. Okay, this is a very normal, basic understanding. Okay, next one. Next one is, this one is very important. FENA. Okay, fractional excretion of sodium. Fractional excretion of sodium. This is extremely important to understand because this will allow us to diagnose a lot of pathological diseases. Fractional excretion of sodium is basically the amount of sodium excreted divided by the amount of sodium filtered. Okay, and once again, excretion rate, we have just studied that excretion rate is UV. Okay, so UV divided by filtered rate, the rate that is filtered. Sodium filtered is basically filtered rate, or the filtered load, okay, is this one that we have already said. This is GFR into the plasma concentration. So let's say that how do we calculate the fractional excretion of sodium? Fractional excretion of sodium is, 1 second, please. Yes, I apologize for that. I just had to take a short call. Okay, so once again, let's go back to our fractional excretion of sodium. Fractional excretion of sodium is sodium excreted minus sodium filtered. Okay, sodium excreted minus sodium filtered. And now the most important way that we can understand this is fractional excretion of sodium. What does that mean? Meaning that the amount of the filtered sodium, the amount of filtration of a substance, or especially sodium in this case, that is excreted. So how much of that filtered substance is being excreted? That is the fractional excretion of the sodium. This is extremely important to understand. For anyone who has previously read the renal system, okay, how important is this to diagnose acute tubular necrosis? Okay, good. Okay, so very important, very important. Okay, so the filtered sodium, the amount of filtered, so the amount of filtered sodium that is being excreted is fractional excretion of sodium. And we have already studied the equations for the excretion. That is, the excretion rate is V into U, or UV. That is the urinary concentration of sodium into the urine flow rate. And we have also studied the filtered load, that is GFR into plasma concentration of the substance. So GFR into plasma concentration of sodium. Okay, and then over there, okay, what we can also do is we can try to rearrange the whole thing. Okay, and over here, if we try to put GFR, which is U, meaning that the urinary creatinine concentration into the urinary flow rate divided by plasma concentration of creatinine, if we try to incorporate this over here, then it will rearrange itself. This equation, you can easily try to rearrange this equation into this final equation. Is this final equation important? Absolutely not. Okay, the reason why is because this is more important than this final equation. I feel like this final equation is more confusing. I would personally try to calculate GFR first with the creatinine, and then put the GFR value over here, and then rest, do the equation, have it solved by itself. Okay, so that's that. Okay, have we understood fractional excretion of sodium? Okay, good, very good. Next one. Okay, next one. Next one is glucose clearance. Next one is glucose clearance. Glucose at a normal plasma level. Okay, glucose at a normal plasma level, which is 60 to 120, is completely reabsorbed in the proximal convoluted tubule by sodium glucose co-transporter. Okay, sodium glucose co-transporter. Now, if I tell you, you guys are at liberty to unmute yourself and answer me this question. So this sodium glucose co-transporter, if there is more than a certain amount, is there a possibility for this co-transporters to get saturated?
Yes.
Yes, of course.
Okay, good, very good. Okay, very good. Okay, so in adults, if a plasma glucose of more than 200 milligram per deciliter is there, okay, glucosuria begins. Okay, glucosuria begins at the rate of 375. All glucose transporters, sodium glucose transporters, are fully saturated, and this is known as transport maximum. So if anyone asks you next time, what is the value of glucose that is responsible for reaching transport maximum, your answer should be 375 milligram per milliliter per 375 milligram per minute. I'm sorry, not milliliter, per minute. Okay. Now, normal pregnancy is associated with increase in GFR. Has everyone, wait, before I move on, has everyone understood this thing? Has everyone understood the transport maximum? Right. Has everyone understood transport maximum? Okay, good, very good. Normal pregnancy is associated with increase in GFR. Okay, with increased filtration of all substances, including glucose, and the glucose threshold occurs at a lower plasma glucose concentration. Now, if I were to ask you, feel free to unmute yourself and answer me this question. What is the threshold level for glucose if glucosuria begins at 200? Okay, I'm sorry, I should have seen that it already says in the text. But what is the glucose threshold level? Come on, guys, it says
Again,
over
doctor.
200 milligrams per deciliter.
200. It says
375.
375 for 200, right?
it says over here. That's why I felt like I asked this question, because it was already here. Look, it says if your glucosuria, the glucosuria meaning the glucose in the urine, if it's present at 200, then obviously the threshold level for glucose is 200. Okay. So there are two things you can be asked. First of all, what is the renal glucose threshold level? Your answer should be 200. If someone asks you, what is the renal glucose transport maximum? Renal glucose transport maximum is when all the glucose transporters have been saturated. So the renal glucose transport maximum is 375. Are we all clear on these two values and what they mean?
So, Dr. Glucosuria
No,
can be
no.
presented while not all receptors got saturated. Yes.
Yes.
Okay.
Okay.
So I have a question about the pregnant lady, the pregnancy paragraph that you're reading.
Mhm.
Um, that the glucosuria will happen at a lower than 200, right?
Right. That in order for everyone to understand this, that's why I wanted to perfect this one over here.
Oh,
So
okay. Sorry.
before I move on to this small text, no reason to apologize, Dr. Tarin. Thank you so much for asking that question. The reason is before we understand this paragraph over here, we have to understand what's happening over here. Okay. First and foremost, okay, for the student who said no, I did not understand. Thank you. Let me allow me to make you understand what's going on. First of all, what's going on is there's a certain plasma level of glucose that you need in order for the proximal convoluted tubule to work properly so that the sodium glucose co-transporter can work. Okay, so if it's anything more than 120, already it's putting a lot of pressure on the channels of proximal convoluted tubule to work so that they can absorb the glucose. Okay, but still they keep on doing it until it reaches a value of 200. Okay, until it reaches a value of 200, at which all the channels get alert. Okay, all the channels are like, okay, we have to keep on working very fast right now because a lot of glucose is coming and we have to work as much as we can to absorb all that glucose. Okay, but what happens is it doesn't matter how much they keep on working. Okay, the channels keep on talking to one another. Okay, you work, I work, and then what happens is they keep on working as much as possible, but they still cannot prevent the glucose to be fully reabsorbed. So some amount of glucose leaves. So glucosuria keeps on happening at 200. Okay, this is the threshold level. This is the level at which the proximal convoluted tubules are all alert. They all start working very deliberately. At a level of 375, all the proximal convoluted tubules are defeated. They are all defeated. They give up and they say, okay, we are all saturated. We don't want to work anymore. Let the glucose come and leave the body. Okay, so at a threshold level of 75, the glucose, the all transporters are fully saturated. So this means that this is the maximum amount of strength the proximal convoluted tubule has. This term is known as transport maximum. Now to that student who said, no, I did not understand. Have you understood now the threshold level and transport maximum?
Yes, thank you.
Okay, you are welcome. Absolutely welcome. Okay, now let's move on to the next paragraph. Normal pregnancy is associated with increase in GFR. Okay, so normal pregnancy right now. So for Dr. Tarin over here, do we have increased blood volume in a person with normal pregnancy?
Yeah, like the plasma
Yes.
levels will double,
Yes.
right?
Okay, everything would increase, so the blood volume would also increase. So with increased blood volume, increased filtration of all substances will occur, including glucose. And the glucose threshold occurs at a lower plasma glucose concentration. Why is this happening? That is because the threshold level over here, what I talked about was at 200, the proximal convoluted tubules are all alert, okay? But this, for the filtered fluid to reach 200, it gradually increases. But in a pregnancy, what happens is the proximal convoluted tubule, when they see that the filtration is so high and there is so much glucose coming, although it's not 200, the sudden increase in glucose alerts the proximal convoluted tubule earlier than it alerts it in a normal person. So as a result, the glucose threshold level, they decrease. Okay, so the glucose threshold level occurs at a lower plasma glucose concentration. As a result, the glucose threshold level decreases because all of a sudden, due to the increasing GFR, there's a sudden increase in glucose in the filtered component of the fluid. As a result, the proximal convoluted tubule are alert at a faster rate. And they try working fast to prevent the glucose to go away, but they can't because the glucose threshold level has decreased, and now glucosuria is occurring at a normal plasma glucose level. Okay, so let's say the normal plasma glucose level is now 60 to 120, but the glucose threshold level has decreased to, let's say, 100. Okay, it has decreased to 100. Why has it decreased to 100? Because suddenly there's been an increase, there's been a sudden increase in the glucose in the filtered load, then the gradual increase that occurs in a person who is not pregnant. Are we clear with this concept? Yes or no?
Yes, sir.
Okay, Dr. Tarin, are we clear with this? Since you
Yes.
question, perfect. Okay, very good. Now let's move forward. Now we have another co-transporter, that is sodium glucose co-transporter. Sodium glucose co-transporters can be inhibited by groups of drugs. I'm pretty sure we have discussed about this in anti-diabetics. That is flozine drugs, canagliflozin, dapagliflozin. These drugs, they block this co-transporter. As a result, if the drugs block this co-transporter, will there be more glucose reabsorption or less glucose reabsorption? Fast answers, please.
Less.
Less.
Glucose reabsorption. If we have more glucose in the filtered load, will this result in increased risk for UTIs
Yes,
Yes.
sure.
and
Yeah.
vaginal yeast infections or any
Can
Yeah.
other
be.
infections?
Yeah.
Yes. So canagliflozins and dapagliflozins. Do you guys remember we talked about the adverse effects of these drugs as UTIs and increased yeast infections?
Yes.
Okay, so so this is the reason. Okay, next one. Glucosuria is an important clinical clue to DM. Okay, we understand that. Okay, that's because there's increased amount of blood glucose. That's that. Splay phenomenon. Okay, splay phenomenon. What is splay phenomenon? Splay phenomenon is basically a transport maximum for glucose is reached gradually rather than sharply due to the heterogeneity of the nephrons. So the different nephrons have different types of the channels which are working. So this is what's happening. So this is the glucose transport. Okay, and this is the plasma glucose. So as the plasma glucose level increases, the filtration increases up to a point where the reabsorption does not increase anymore. Okay, so the reabsorption rate increases. At this point, there is complete saturation and there is gradual decrease of reabsorption, and most of the glucose is freely filtered and excreted. Okay, this is not a very high yield diagram for your exam, but it's important to understand what this is happening is that there is a gradual reach of the transport maximum rather than a sudden reach of the transport maximum. The kidney tries the best it can in order to save the glucose, but at 375, every part of the proximal convoluted tubule is saturated, and the transport maximum is reached and the glucose is freely filtered away. Okay, are we clear on this? Are we cleared on this? Are we clear on this topic? Repeat pregnancy. In pregnancy, do we have increased blood volume, Dr. Karbasi, or decreased blood volume? Dr. Karbasi, increased blood volume. If we have increased blood volume, do we have increased GFR? Okay. If we have increased GFR, is there a chance for an increased amount of glucose to enter into the filtered substance? Yes. Okay. If there is a sudden increase in glucose, will this alert the proximal convoluted tubule channels? Okay. So if they try to work really hard once again, will this decrease the renal threshold level for glucose once again? Because they activate it fast for no reason? Yes. If the renal threshold level decreases, so glucosuria can happen at a normal glucose level. Are we clear? Okay. Okay. Having said that, has everyone understood the lecture? Okay. Can we get some feedbacks from the students who are not actively participating? Okay. Students who are not actively participating, have you understood the lecture for today? Okay. Okay, perfect. Thank you so much. Okay, having said that, do you guys want to move forward or do you guys want to start where you wrote notes? Stop, please. Okay. Okay. I got so scared. People said, stop, please. I thought I was doing something wrong, to be honest. But, okay. Can you please answer that question? Of course, I can answer your question. What is your question once again? Let's see what your question is. GFR is calculated by inulin or creatinine levels. GFR is calculated by both inulin and creatinine levels, but creatinine has an creatinine is known to overestimate the GFR because creatinine is a broken metabolic product of muscle breakdown. So it's better to use inulin instead of creatinine, but both can be used to measure GFR. Are we clear? Okay, you are well. Okay, so no problem. Can you explain to me the end again of page 583? Page 583. Which one is page 583? Okay, this one. Okay. First of all, if okay, let's go back to this table. This table is high yield, and let's help out Dr. Kavazi. First of all, efferent arteriolar constriction. Efferent arterial. Okay, can I have my students unmute themselves and help me out with this once again?
Yes.
Okay. Wait for a minute. Okay, now you guys can help me out. Okay. Okay, so who do we have? Who do we have over here who's helping us out today? Helping us out right now? What are the names of the physicians who are going to help us? Can we have Dr. Karbasi unmute himself and also help us out? Dr. Karbasi, if you are kind enough to please unmute yourself, because since you have the problem on understanding with this, I would be more than happy to make you understand this directly. Okay, what's going on over here? If there's an efferent arteriolar constriction, if the efferent arteriole is constricted, will there be more renal plasma flow or less renal plasma flow? First question.
Less, right?
Less renal plasma flow, right? If there's less renal plasma flow, what about the GFR?
Has to be also less because blood can't enter the kidney. Like the yeah.
Okay, so as a result, the GFR will also decrease. If GFR decreases and renal plasma flow decreases at the same time, at the same level, do you think this will have any changes in the filtration fraction?
Yes, it will be less.
No change. There will be no change.
No change.
No,
Sorry.
no change.
No change. Sorry, no change.
Okay, no problem. No problem. Next one is efferent arteriolar constriction. If there's efferent arteriolar constriction, will there be more GFR or less GFR?
It has to be more, right?
More.
More GFR because the hydrostatic pressure will increase, as we have just discussed with Dr. Hassan. Okay, she asked that question before. How does GFR increase in efferent arteriolar constriction? As a result, if we have obstruction, pressure increases. Did I hear a question coming?
Oh, I guess you can understand it in the way that like it's not exiting, so it spends more time to be filtered, right? So
right. So as a result, the pressure which increases is hydrostatic pressure, right? So that's okay. So that's the thing. If hydrostatic pressure increases, the GFR will increase. If GFR increases, Dr. Karbasi, are we clear on this? That the GFR increases in efferent arteriolar constriction? Dr. Karbasi, are we clear on this? Okay, but
yeah, because it stays more in the kidney, right? Yes.
Okay. You don't sound very confident.
Yes, can you hear me? Yes, can you?
Right now, this is what my drawing is. Okay, look at this drawing. More fluid, according to Dr. Tarin, will spend over here. Okay, if there's more fluid over here because there is an efferent arteriolar constriction, okay, this will put pressure and as a result increase the hydrostatic pressure in this segment. And this segment is also freely permeable to filter out. So will there be more GFR or less GFR if there's an efferent arteriolar constriction, Dr. Karbasi?
More.
More.
More
More.
GFR. Now we understand. So there will be more GFR. As a result, GFR increases and renal plasma flow obviously will decrease because no renal plasma flow can increase with the constriction over here. So renal plasma flow will decrease and GFR will increase. As a result, filtration fraction will increase. Am I correct? Yes or no?
Yes.
Yes.
If there's increased plasma concentration in this part, now the plasma concentration, the plasma oncotic pressure has increased. Can GFR increase or decrease? Will GFR increase or decrease? Plasma
Decrease.
GFR will decrease. Why? Why will GFR decrease? Because plasma oncotic pressure
Because
has a,
increased plasma oncotic pressure.
right. They have a tendency of pulling the fluid. Okay. So as a result, GFR will decrease. If GFR decreases, increase or decrease in plasma protein concentration will not hamper the renal plasma flow. They will stay as it is, whatever. And as a result, if GFR decreases, filtration fraction will decrease because renal plasma flow
Decrease.
will not change, and vice versa. For decreased plasma protein, there will be increase in GFR. Dr. Karbasi, are we clear because of this?
Yes.
Okay, good, very good. Next one is constriction of the ureter. If there is ureteric constriction, there will be backflow of urine. As a result, the hydrostatic pressure over here in this space will increase, which will put a lot of pressure and prevent the fluid to be filtered from here to here, right? As a result, there will be less GFR. GFR will decrease, renal plasma flow will not be hampered, and once again, filtration fraction will decrease. Okay, and last one is dehydration. If dehydration is there, there will be a severe decrease in renal plasma flow. GFR will also decrease, but renal plasma flow will decrease 3 times more than the GFR. As a result, filtration fraction in dehydration will increase.
I have a question.
Yes, what's your question, please?
For the plasma protein, like the up and down arrows, it's talking about the symbol that the aquatic pressure GC, right?
Right.
Not not
No,
Bowman space.
no.
Okay.
Not the Bowman space because the oncotic pressure in the GC is important mostly for, I mean, okay, so think about nephrotic syndrome. If you have a patient with nephrotic syndrome, there is a loss of protein. Will it affect the oncotic pressure in the GC or the BS?
GC.
GC.
GC. If we also
GC.
have another condition, let's say we have primary amyloidosis. Okay, will there be increased plasma? Will there be increased protein or less decreased protein?
Increase.
Primary amyloidosis.
Increase, I
There,
guess.
Increased
there will
protein.
be increase in
More
tissue.
protein, right? So if there's
Yeah.
more protein, will this hamper the plasma protein in the GC or the BS?
BS must
GC.
No, not
GC.
BS.
GC.
GC. More protein in the blood. GC. Okay. The plasma protein, the plasma oncotic pressure in the BC will be in BS will remain more or less the same, not really affected by anything else.
Mhm.
Okay. Are we clear?
Yes.
Yeah.
Okay. Why are we not confident enough? Why are we not like,
Sorry,
yeah?
to be honest, I
Yeah,
just
this
kind of
is-
got confused.
okay.
So I'm not confident in this.
Okay.
Like
Which
I
one
don't
do
know
you
what's
have the
going on.
confusion in?
With the GC and the BS.
Okay, I'd be more than happy to clear away your confusion. Okay, this is the GC portion. This is the BS portion. Okay, which portion of this is the one where the the blood of the body is carrying the substances A or GC or BS?
That's GC.
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 All the changes that occurs in the blood, are they not the reason for the increase or decrease in plasma concentration?
Yes.
Okay, if we have nephrotic syndrome or like anything, will it hamper the protein in this part or in this part?
And GC.
GC.
So
So
no
it's
matter
in the
what
blood.
happens, exactly. So no matter what happens, decrease of plasma protein or increase of plasma protein will hamper the content of the oncotic pressure in the GC.
So what's
Having
the
said
use of BS then?
that, okay, good.
If
Having said that,
everything's happening in GC.
right. Having said that, the BS portion over here is if we have any hydronephrotic condition. First of all, the hydrostatic pressure in BS will increase, which will decrease the GFR. For example, constriction of ureter, that's number one. Also, also, there's another way how oncotic pressure in BS can increase. Okay, if we have ATN or acute tubular necrosis, then all the portions of the PCT, meaning the proximal convoluted tubule, is being ripped off and it's being accumulated in the Bowman space, right? At this point, will there be increase of the oncotic pressure? Yes or no? If there's
Yes.
exactly. So that is also another condition where the oncotic pressure in BS will increase. But having said that, if you can only understand that plasma protein concentration increase over here will pull the fluid from here to here, and plasma protein concentration over here will pull the fluid from here to here, and the vice versa goes for the hydrostatic pressure, you should be absolutely golden. Are we clear?
Okay. Yeah.
So if I understand correctly, so I have to compare like the pressure like between the Bowman's caps and Bowman space,
Mhm.
and then I can find out like which was gonna be like influencing the other.
Right. Yeah, exactly. That's more or less that's what it is. Okay. Uh,
So where the protein goes, the pressure goes.
well, you can
Kind of.
also say that for the
Oncotic
hydrostatic.
pressure.
Okay, okay. Let's talk about osmosis. Okay, what is osmosis?
High to low.
Okay, let me draw this thing over here. Okay.
This is more complex than urology, to be honest.
No, it's not complex at all. It's actually very simple. Okay. Let me break it down for you. You'll understand. Okay. Are you guys
Thank
all
you.
acquainted with the? I'm sure you guys are all acquainted with. It will be insulting for me to ask you guys if you guys know what osmosis is or not. I'm pretty sure you guys know what osmosis is. Okay. Okay. So what's osmosis over here? Okay. Free fluid, permeable membrane. Now what we have is solutes. 3, 4, 5. 5 over here, 2 over here. Okay. Now, A, B. Which way should the fluid move from
A to B.
From A,
B
B.
to A.
B to A.
Oh, the fluids or the solute?
The fluids.
B
Just
to
a
A.
minute. The particles, are they protein or like osmotic particles?
They are basically solutes. They are
Ah.
solute. Which way shall the fluid move? From
A to
higher
A.
concentration to lower concentration or from
High
low?
to low.
I
To
to
B.
know, A to B.
From A to B.
So why
From
will
A to
they?
B.
To A.
According to pressure,
One
B
second.
to A.
Okay, one second.
oncotic or
B to
Over
A.
here, over here. One
confused.
second. One second. Okay, basic knowledge. Basic knowledge. 1 second. Over here, you have 2 solutes. Okay, 2 substances. Over here, you have
A to
5
B.
substances. Okay. If the fluid has to move to a space where they have more space for the fluid to get accumulated, which first of all, answer me this. And you know what? As a matter of fact, let me use not everyone. Let me ask Dr. Tarin, Dr. Karbasi. Okay, since you
Yes.
guys are the one with the most issue. Okay, so let me ask Dr. Tarin first. Dr. Tarin, which part has more space for the fluid to go to, A or B?
B.
B. So the fluid will move
A
from
to B.
A to B. Why will they ever move from B to A? Because fluids will always move from its area of higher concentration of solute
To lower
or
concentration.
concentration of solute. Okay, but
Mhm.
from
Yeah,
the
I
lower
have question.
concentration of
But fluid is more in B, right?
Huh?
Yeah, but fluid
But
more.
fluid is more concentrated in B.
The fluid is more concentrated. Okay, okay. This is
What?
getting
I'm
very,
so confused.
this is getting very confusing. Okay.
ليش يلا
I'm getting confused. Okay. Okay. And now we have people shouting A and B. Okay, wait 1 second. Just give me 1 second.
Doctor, you can put it in a very simple way. You can draw 2 buckets.
I think what was confusing was that the fact that you were saying fluid and then solute, and then people were thinking of the water that the green particles are in,
Okay,
and
no
then the
more
green
water.
circles
Okay.
themselves.
No more particle, no more water. We will go straight away to kidney. Okay. Okay. Now let's talk.
Doctor, due to osmosis, it
No
should
more
be
osmosis.
from
We're
the
not
higher
gonna talk about
concentration
osmosis.
to the lower concentration, right?
Right, but we're not going to talk about osmosis anymore. We're going to straight away jump to this one, okay? Because I'm pretty sure you guys will understand from over here. Okay, all I want to hear is, does this Does this fluid in this canal over here, does it have a certain hydrostatic pressure? Yes or no?
Yes.
Okay.
Yes.
Does it have a certain oncotic pressure? Yes or no?
Yes.
Yes.
Hydrostatic pressure, which way will it push? A to B or B to A?
Yes.
A to
A to
B.
A
B.
to
A
B.
to B.
Okay.
A to B.
A to B. Okay. Next one is oncotic pressure. Which way will it push?
B
B
to
to
A.
A.
B to A.
B to A. Meaning that this thing will pull the fluid from here to here. Okay.
Deabsorption.
Now my question is, if there is a net fluid to happen, is there a possibility you can subtract these two pressures?
Yes.
What does
Yes.
it mean not
Yes.
fluid, doctor? What does it
Okay.
mean not fluid? Not
Okay.
fluid.
Okay. Now the fluid that is accumulating over here, okay, this fluid also has a hydrostatic pressure.
Yes.
Yes.
This fluid also has an oncotic pressure. Okay.
Yes.
This
Yes.
hydrostatic pressure will push from A to B or from B to A.
From B.
Yes,
From B
to
A
to
to
A. Yeah.
B.
This
B to
hydrostatic
A.
No, B to A because he wants to
It would
push it
go
away.
opposite. Yeah. B to
Right.
A.
and oncotic pressure, which way
A
will
to B.
A to
A to
B.
To
B.
B.
to be? Right now, after drawing these four pressures, the pressures which are working on the same side, can we add them? Yes or no?
Yes.
Why not?
Mhm.
If we add this one plus this one, and
Same side
then
minus.
if we subtract this from this, can we get the net pressure?
Yes.
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 Okay, so that's exactly what's going on. Can you just give me 1 second, please?
Guys, I don't know what you.
Yes. Well, I apologize for taking that small break. Okay. So this is what's going on over here right now. Okay. As a matter of fact, so what did we stand? So where did we finalize the whole thing? We finalized the whole thing in the fact that we have to add the pressures which are going on the same side, and then we can subtract the pressures which are going on the opposite side. As a result, if we do that, then we can get a net filtration pressure. Net filtration.
So,
okay. Now what's the
so
question?
A is Bowman capsule and B is Bowman space, or
A
like
is the glomerular capillaries. B is the okay.
B is Bowman space and A is glomerular capillary. Okay.
Okay. Are we all clear finally?
Yes.
I think so. Yeah. I think so. Yeah.
Yes.
Any more questions on anything else?
No.
Like the diagram is like finally on first aid on the page on first aid is finally that what you explain us, right?
Yes, basically I explained this time. explain this diagram. Okay.
Okay. Yeah, because small question. Sorry for that. Because we said that the RPF is also in the blood room, right? So
Mm-hmm.
so it also enters through the efferent arteriole. But if I constrict the efferent arteriole, why I said the RPF is decreased, because it's still also in the efferent arteriole.
Mm-hmm. If you
Like, do you know
yes,
what I
if you
mean?
constrict the efferent arteriole, will there be more blood coming to this side or less blood?
Like to this type,
Less.
less.
Less blood. If blood decreases, can the plasma flow also decrease because the component of the fluid contains blood and plasma?
Yes.
Yes. So as a result, if you have efferent arteriolar constriction, then renal plasma flow will decrease.
Okay. Okay.
Okay.
Got it. Got it.
Okay.
Okay. Got it.
Okay. Does anyone have any more confusions? Any more problems?
No.
The chat.
No,
Okay. No more problems, no more confusion. And having said, do you guys want to continue further or leave it over here and move on to UWorld? Okay. I
you're
am very, very sorry for confusing you if I did, but I do not want you guys to leave the lecture confused. Okay. I do not want you guys the lecture being confused. Please clear your confusion with me right now before you complete today's class. Okay. If you have any confusion, do not hesitate to ask me. And having said that, in order to clear our heads, can we take a break? Can we take a 5-minute break for fractional excretion of sodium? Fractional excretion of sodium is sodium excreted divided by sodium filtered. Sodium excreted is U into V. Sodium filtered is GFR into plasma concentration of the sodium. So, okay, so fractional excretion of sodium is basically the amount of filtered sodium that is being excreted. So that is fractional excretion of the sodium. Okay. From page 581, high yield summary. Okay, of course. High yield summary from page
The
581.
physiology part, only the physiology part.
Okay. If you're not, we will also send you the lecture so you won't be missing out anything. High yield summaries are, we talked about the importance of the course of the ureter, okay, and how it's important that you understand that the ureter goes beneath the uterine artery and over the common iliac artery. Then we talked about the blood supply, that is the closest is RA, next is gonadal, aorta, common iliac. The closest one to the bladder is superior vesical artery, supply the ureter, so proximal, middle, distal. Then we talked about the different body compartments with water. That is 60% is water, 40% is not water. Out of 60%, we have 40% of the total body mass, not 40% of 60%. We have the 40% of total body mass, which is ICF, and 20% of total body mass, which is ECF. Then we talked about glomerular filtration barrier. We talked about the layers, that is finished capillary endothelium, type for collagens, and the podocyte food processes, how you need a certain charge, that is a negative charge, will repel another negative charge substance, and you need a size, that is the size have to be less than 100 nanometer in order to go through the barriers. If it's more than 100 nanometer, it will not go through the podocytes. If it's more than 50 to 60, it will not go through the slit diaphragm. Okay, that's all we talked about. Normal GFR per day, 180 liters per day, a minute, 1 minute. Any other question? Okay, is everyone back from their break? Is everyone back from their break? Okay. Okay, good. We had quite a lecture today. Okay, a lot of active participations, a lot of questions, a lot of confusions, but gladly all those confusions should be cleared by now. Okay. And having said that, have you guys understood the lecture for today? Can I get yes or no? Okay. Okay, good. Okay, good. And are we ready to begin the URL notes section of our lecture? Okay. So let's begin with the URL notes. Okay. Okay, before we begin the URL notes, can I ask some last questions regarding the last confusion so that we are all on the same page? And please feel free to unmute yourselves. Can we have the doctors with the who were involved in our discussion? We have Dr. Mohammed, then on the how's the voice? Okay.
Mm-hmm.
Okay, can you guys hear my voice now? Is the voice clearer?
Yes.
Okay, good. Can we have the doctors with the with whom we were having the discussion? Dr. Karbasi, Hussam, Dr. Tari, and another doctor. Okay, my first question is for Dr. Tari. Okay, if we have increased hydrostatic pressure in the GC, will the fluid move from GC to BS or from BS to GC? Again, I'm
GC
sorry.
to BS.
Okay, I apologize for asking the same questions again and again. It's only for helping everyone out so that we can understand the whole thing. Okay, good. The next question goes to Dr. Hassam. If we have an increased oncotic pressure in BS, will it move the fluid from GC to BS or from BS to GC?
From GC to BS.
Wrong.
Because you said oncotic pressure in BS, so fluid will follow oncotic.
Fluid will move from GC to BS or from BS to GC if the oncotic pressure in BS is increased.
GC to BS.
GC to BS.
Okay. Okay. So we have to go back to our discussion again. Okay.
Oh my God.
Really? What? Oh my.
He said BS.
Yes.
Doctor,
It's okay.
BS,
I'll just, you know what? It's fine. We'll answer 2 questions on step.
Dr. Hassan.
Doctor, you said if protein increase in
Okay,
BS.
ask him again. Ask him
Okay,
again.
and we're back to our discussion. Okay, once again. Yes, GC. Okay, increased oncotic pressure. Increased oncotic pressure.
We can't see this in your screen.
Which way will the fluid move?
We cannot.
We can see the screen.
Doctor, you...
No screen, doctor.
No screen.
One second. I'm sorry. Okay, now. Which way will the fluid move? A to B or B to A? If
Where
the
What was the question?
The question was, okay, my question was, if the oncotic pressure over here increases, will the fluid move from here to here? That is from A to B?
Yes.
A to B, yeah.
Yes, yes.
Yeah.
From A to B if the oncotic pressure increase and B.
Right.
Okay.
Just then.
Why will the fluid move from GC to BS?
Because oncotic
Because
pressure is
fluid-
like
Oncotic pressure.
absorbing.
Opposite direction.
Yeah,
Oncotic
because
pull.
protein attract the fluid.
The oncotic pressure will be attracting the
Yes.
fluid from over here.
Yeah.
Okay.
Yeah.
So if the hydrostatic pressure over here is increased, then the fluid will move from A to B. Now, my next question is, for Dr. Mohammed. If the hydrostatic pressure over in BS increases, which way will the fluid move?
From B to A.
Very good. From B to A. Okay. And the last question is for Dr. Tari. If the oncotic pressure is increased over here, which way will the fluid move?
B to A.
B to A. Okay. Are we finally clear with everything?
Yeah.
Yes.
Yes, yes.
Yes.
Yes, it's super clear, doctor.
That's super
Shut
clear
up,
to everyone. It's so super clear that Dr. Wassam does not want to get picked ever again. Okay. So very good. Okay. So now what we will do is we will ask everyone to unmute themselves and be at liberty to use their mic to answer me questions regarding the UWorld notes. Okay. Just as how we do every day, so that it will save me some time, prevent me from going to the chat box, and prevent wasting time. Okay. First, my first question. Have you guys heard of a condition called, it's a sports injury. Have you guys heard of a condition called jersey fingers? Yes or no? Okay. I'm guessing the answer is no. Okay. So
No.
basically, jersey fingers are basically, let's say if you have a football player, okay, let's say if you have a football player, this is a UWorld question, and the
I think the
opponent's
Tom flexure.
I'm sorry, what was the question?
There's something called like Tom something.
I'm not sure if that's what it's called, but there's a proper term for this injury called the jersey finger. So what's happening over here is the opponent's jerseys, what they do is, you know, like how jerseys have some space in them. So by jersey, I mean the t-shirt which the opponent is wearing. And if you have the player's finger stuck at the opponent's jersey spots, okay, that is space in the jerseys. And if the opponent moves away, okay, if the opponent moves away, will it not cause damage to the finger if the finger is stuck? Yes or no?
Yes.
Okay. Let me show you what's going on over here. Okay, this is a very important question because the question is involved by mentioning the term that is jersey fingers. Okay, and the reason why I'm discussing this is because you will get this question and you will recently added or in emboss. Okay, so let's say that this is the football player and this is the football player's jersey. Okay, that the football player is wearing.
Oh, I remember this.
Very good. This means
It's
that
the finger bending down, right?
right. Okay, so you know the spaces over here. So if I am the player who is working against this player, if my finger gets stuck over here, okay, this can happen in the contact sports. Okay, if my fingers are stuck over here, right, and if this guy he moves back, will this not cause damage to my finger? Yes or no?
Good.
Yes.
Yes. Now the question is, which tendon will get ruptured?
Flexor tendon.
The flexor.
Flexor digitorum.
Flexor digitorum, very close.
Superficialis.
Superficialis.
Nope.
So profundus.
Profundus.
If it's not, it has to be profundus. Okay, rupture of flexor digitorum profundus tendon. Thank you so much. That is the question. Please look out for this question in UWorld. And also, if you're doing MPOS, then 100% you should be getting this question at least 3 times. Okay. My next question is 5-fluorouracil. What is the prodrug from where 5-fluorouracil comes? I discussed about it.
Capecitabine.
Very good.
Capecitabine.
Okay. And my next question is, which enzyme does it inhibit?
Thymidylate
synthase.
Very good. Okay. Okay, next one. Next one is, in spontaneous deamination, what type of excision repair damage do we have? What type of excision repair damage should be done? What type of repair should be done? That's my question. Nucleotide excision, base
Oh,
excision.
base excision repair.
Very good. Base excision repair. Okay. What is the first enzyme that is required for base excision repair?
Xenoclease?
No, that's not the first enzyme. The first enzyme. What is the first enzyme that is required to initiate the process?
Oh, I know.
Glycosylate.
Very good.
DNA polymerase. So
Nope.
no.
Dr. Adhanom was the one with the correct answer. So thank you, Dr. Adhanom. Thank you, Dr. Tarin, and also Dr. Hossam. Thank you for trying. Okay, next one. Next one is, what's the name of the drug that we use in erectile dysfunction?
Sildenafil.
Sildenafils.
Sildenafil.
Sildenafil.
Yeah.
Erectile dysfunction. Yeah,
Yahim
Viagra,
Bimin.
right?
Right.
Is it not Yamibin?
Is that a phosphodiesterase 5 inhibitor?
Yes.
Yes.
Now my question is, which part of the male genital organ?
Oh, cavernosa.
Cavernos should be.
Very good. Acts on corpus cavern.
They gave the histo of it and told you to point at it.
Yes, that's what they did. Right. You remember the question? That's what it was.
Yeah, I think it was NBME or you were.
This was taken from NBME. This was also
NBME, yeah.
Yeah, this was also present in AMBOS. Okay, so very high yield, very high yield. Okay, next one. Can you guys name a drug that targets CD52? Very important for NBME once again. Okay, so long silence. No answer. The answer is
Altuzumab? Altemizumab? I can
Alan.
spell it, but I can't say it.
Okay, Alim2
Alimtumab.
Okay, Alim2 Mumab. Okay, good.
In which disease we use it, doctor?
Alim2-zumab, sorry, not Mumab. My apologies. Alim2-zumab. Which disease we use it? At this point, I apologize. The name of the disease is not coming to my mind. Okay.
Me also.
I cannot remember the name of the disease. If you guys can name one, that's good on you. But for some reason, I can't name it.
Some are saying in the chat CLL.
CLL might be okay, but that's not. So the problem with these questions are, even in CLL, alemtuzumab is not your first drug of choice. Okay, these are not
even MS, I think.
Right. Even in MS and all types of autoimmune. But the thing basically is drugs which will target your cluster differentiations are the drugs which are used in autoimmune diseases. Okay, but having said that, drugs such as monoclonal antibodies, such as alemtuzumab targeting CD52, these are not the first drugs of choice as of yet. Okay, these questions are created to make sure certain exams are very difficult, to get those, to separate the easy students from the students who go an extra mile to receive that to receive that better score. Because you wouldn't expect a student who's expecting to get 196 or 200 in the USMLE step 1 remember a drug such as alemtuzumab. Okay, they would try to focus on mastering just nothing but the basic concepts. But these extra knowledges about the names of the drugs, which should not be asked very frequently in step 1, but they are still asked because they want to differentiate the good from the best. Basically that. So if you want to have that higher score, maybe you have to go that higher mile. If not, it's not that important to understand the names of these drugs. Okay.
Doctor, is that true that from next year there will not be a mark in the USMLE exam? It will be just passed or failed, right? I heard it like
That's
that.
2021.
2022.
January.
Right? 2022.
Sorry, 2022.
Yes,
what year are we in? 2020.
Yeah, 2020. So it's 2022. Okay. From 2022. Yes. So step 1 will be pass and fail. The only numerical value will stay for step 2 CK. Okay. My next question is okay, lichen planus, almost said the answer myself. What do you expect in the histology?
Hypergranulosa.
Okay, that is a very good answer. But another thing that we see at the dermal-epidermal junction.
Yeah, there is increase, elongation, like
sawtooth appearance.
Okay, Next one. Next one is BMI is normal, so normal BMI, but there are signs, symptoms of type 2 diabetes mellitus. Okay.
Yeah, moody.
Very good. Okay, very good. Maturity onset diabetes mellitus. Now the question is not that. The question is which enzyme is defective?
Glucokinase.
Very good. Okay.
And it's autosomal dominant, yeah?
Yes. Okay. How do we treat this? How do we
You
treat
give
this?
the enzyme?
No, not really. We just, there's no point in giving glucokinase because administrations of glucokinase will result in breakdown of the enzyme. Okay. So what we do is these patients, we ask them to maintain a lifestyle with diet and exercise. As simple as that. Nothing else. If nothing works, then the next step we go for is metformin. And by metformin should work. If by any chance metformin does not work, and that is very rare, for MODI, what we use is insulin. That's it. Okay. Next question. In infectious mononucleosis, is this a cold agglutination disease or a warm agglutination?
I think cold.
Warm.
Cold.
Cold. Miserable yeah, cold.
So do we have IgG or IgM against the RBC?
IgM.
M.
Now, the answer is, as a result, what happens to haptoglobin? Does it increase or decrease?
Decrease.
Is everyone on the same page?
Decrease.
Everyone on the same page as haptoglobin
Yes,
decreases?
Yes. Decrease. Okay.
Why does haptoglobin decrease?
Because of hemolysis.
It's taking up the broken down RBCs or the ones that are.
Right. Very good. That's what it is. Okay. Okay. Next one is a statement. It's not a question. Okay. So look out for these things. That is, CMV infections can cause dystrophic calcifications. This is just a statement. Just look out for this. Keep in mind that you will have a lot of CMV questions in your USMLE Step 1 exam, specifically connected to AIDS patient or immunocompromised patients or SCID patients. Okay, and try to look out for calcification, specifically dystrophic calcifications in these patients. Okay. Next question: cyanide toxicity. How will you treat a patient with cyanide toxicity?
Amyl nitrate.
Amyl nitrate. That's one. Anything else?
And something else with nitrate also.
Did we not discuss this once before? I think we did. Okay,
Yes.
so first thing we will give is amyl nitrate. What's the second thing that we will prescribe to this patient? I'm sorry?
Sulfonides.
Can we prescribe sodium thiosulfate?
Yes, I think.
Yes.
Can we prescribe hydroxycobalamin?
Yes, B12.
This is a very high yield question. We will discuss this in details again, okay? But for now, just try to keep in mind, if you receive any questions like this, then these are your answers. Okay, good. Are we all acquainted with the term that is physiological dead space?
Yes.
Okay. Can anyone be kind enough to make me understand what physiological dead space is?
When there is, let's suppose, obstruction in microvessels in lung.
That's where gas exchange doesn't happen.
Right.
Yeah.
It's physiological. Basically, the portion of the lung that is not involved in gaseous exchange is a physiological death. Okay. My question to you guys is, during exercise, do we have increased physiological dead space or decreased?
Decreased.
Why?
Because you need more air in.
Because vasodilation.
Blood supply increase. That's why
When we have during exercise, there is bronchodilation, Okay, more air can flow in and more area for gaseous exchange. So gaseous exchange increases. As a result, physiological dead space decreases. Okay, next one. Next one is, okay, are we all acquainted with postpartum hemorrhage?
Yes.
Yes.
Okay, good. Now, my question is, if you have a patient with PPH, the number one cause of PPH is an atonic uterus. Okay, so you increase the tonicity, you do whatever you have to do, but then you realize that there is a piece of placenta attached to the uterus. And so what you do is you remove the placenta, attached placenta. So PPH after placental removal. So the PPH still does not stop. What type of a placenta was this?
Placenta
Acrita.
Acrita.
Okay. Why does placenta accreta happen?
Because it invade deep
It invades the muscles.
Myometrium.
the muscles.
Myometrium.
It invades the muscle. We understand that, but why is it invading the muscle?
Improper implantation.
Do we understand that the uterus has two layers, out of which one layer is known as the decidual layer?
Yeah.
Okay.
Yeah.
If there is a
The
defect,
phallus.
if there is a defect in the decidual layer, does it result in stronger
Vision.
or a weaker uterus?
Weak.
Weaker uterus. If the uteral layer, one of the layer is weak, will this allow the placenta to penetrate more or penetrate less?
More.
Penetrate more.
So if it penetrates more, can they reach the muscular layer then?
Yes.
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 So placenta accreta occurs because due to defective
Decrease.
Decidual.
decidual
DEC.
layer. Okay. Okay. Next one. Have you ever heard of a brown reclusing spider?
Yes.
Anyone?
Yeah.
Okay, this bad boy over here. Okay, this one. Okay, this is very important medically. Okay, because a lot of South American patients will come with a bite from this kind of spider. Very dangerous. Okay, very. Some of them are actually quite big. Now, what happens when you have a bite from a brown reclusing spider? My question. What do you think will happen? I'm sure you guys have not heard about this because it's not common in
Yeah.
from.
Spongio.
Okay, and
The IC maybe.
okay, now understand this. Okay, when you get a question like this, let's say you are giving your USMLE step 1 exam, and all of a sudden you get a question like this which you have no idea about. You have no idea about. They come and tell you that you have a patient who has brown reclusing spider bite. What is the number one pathological change you're expecting in that area? Over that, if there is inflammation is the number one, sure. But if it's a spider bite, what will happen is the spider bites, they usually, what they do is they
Blood
use
sludge.
cell killing.
Necrosis then.
There we go. So do not get worried. The only thing that they want you to understand is spider bites and snake bites can cause severe necrosis. Okay.
What about blood sludge, doctor?
What about what?
Blood sludge.
That will also be due to blood sludge. Is that what you said?
Yeah.
Blood sludge. Blood sludge. I'm not sure if I'm well acquainted with that term, but the thing is, what I wanted you to, I mean, like what I wanted to get through to you is, if they ever ask you questions which you have no idea about, try to tap into that basic concept of pathology. The tapping into that basic concept of pathology, meaning that if there is a cellular trauma, the number one is cellular inflammation. If that trauma stays for a long period of time without proper regeneration, then you get cellular necrosis or apoptosis. Out of all of this, the only thing that NBME would like you to know, this is an NBME question, most probably from NBME 22 or 23, which is the recent ones, is that the brown reclusing spider bites can cause severe necrosis. And that's all you want to know from this question. That's all they want to know, that whether you can understand, and they just want to throw you off from your skills, and they want to confuse you So that's the reason why I discussed this question, or else I would have left it out. Okay, next one is leuprolide. What is leuprolide?
G gonadotropin releasing activator agonist.
Agonist.
Is it long acting or short acting?
Short.
Long
short?
acting. Nope. It's a long acting. Okay.
Ah.
First of all, what will they do to testosterone and DHT initially?
Initially,
Increase it.
increase initially.
And then it decreases.
Right. Okay. Have you guys heard about Becker's muscular?
Yes.
Yeah.
Yes.
Very good. What is the genetic deletion in Becker's muscular dystrophy?
Mutation in dystrophy.
Dystrophy.
Genetic deletion.
Mutation.
We have silent mutation, nonsense, frame shift.
This is
shift.
Non-frame shift.
Then we have another one. Is it
Missense.
a deletion or an out of frame deletion?
It's not frame deletion.
In frame makes sense.
I think it's non-frame shift.
Non-frame.
Mutation.
The DMD is frame.
DMD. DMD.
Yeah. Baker is non-frame.
Baker is
It's non-frame.
Is it frame shift or not frame shift?
Not frame shift.
Non-frame shift deletion in the dystrophin.
Okay.
Yeah.
Okay. Now, another one is DMD. Obviously.
Frame shift mutation.
Okay.
DMD is muscular dystrophy.
Yes.
Frame shift.
Okay. Okay. Next one. Next one is okay. 1 second. Okay. This is a clinical scenario of a patient who has fever, abdominal pain with pre-existing ascites. What is your diagnosis?
Spontaneous
bacterial
peritonitis.
Absolutely brilliant.
SBP.
Spontaneous bacterial peritonitis. What do we give these patients?
Gram-negative antibiotic.
We give them antibiotics.
Yes.
But
Cephalosporin
the number
3.
one antibiotic that we can give to this patient, according to you world.
Cefizidine.
Ceftriaxone.
Basically, what they were looking for is the answer is
Cephalosporin.
galactamine.
Or cephalosporin.
Beta-lactam. It's like the name of the group.
Right. If there is beta-lactam failure due to resistance, what is the next choice of antibiotic? Okay.
Macrolide.
Okay. If I have to ask you something, let's say that you have gram-negative infections in the body. If it's above the waist, what antibiotic are you going to give? If it's below the waist, what antibiotic are you going to give?
Below is
Below for clindamycin or above for clindamycin?
Metronidazole below. Clindamycin above.
Okay.
clindamycin is above.
Clindamycin above it.
And metronidazole is for below.
Below.
You guys want to do some more questions? Okay.
Can I ask a question? For the deletions, maybe next class or something, can we go through just like a few of them, like the how to distinguish? Because in UWorld, I feel like I get a lot of the questions wrong just by the term, like between essence, nonsense, silent, and I guess it kind of gets confusing.
Okay, so what we can do is, instead of starting the discussion topic in between renal, which might cause confusion, what we can do is, since this is causing some problems, we can try making a separate lecture for this, and we will put it out for everyone to see. Okay, so that everyone can tap into that lecture and understand this. So we can make a separate lecture out of this. And obviously, when we study genetics and biochemistry, we will be studying this else. But since we have some problems regarding this mutation thing, what we will do is we will make a lecture out of this separately, and we will post it on the page. So will that help?
Okay. Yeah.
Good.
Please, I have question.
Can you also do that for antibiotics?
Okay, so if we keep on doing it for everything, then that would be an issue. Okay, so
Just two things.
okay, so
Just two things: mutations and
on the next
antibiotics.
time we'll have students coming. Okay, sir, I think it's about time you start your lectures on biochemistry. Okay, but what we would do is, since you have the problem with the mutation, of course we will make that video on the mutation and antibiotics. We will also take that into consideration. Does anyone else have any other things they would like us to make videos on, just in case, from the topics which are different from which we are studying right now? I would be more than happy to. Okay, I apologize. I was just joking, to be honest.
Yeah, genetics in general would be perfect.
Genetics and biochemistry, that's a big topic to make a single lecture on. We will take a lecture on that one. But the thing is there any small topic in particular which you need help with?
You made a really good video on the topic I didn't understand for transposition and transduction. That was really good for biochem.
Yes, we did that for bacterial.
Yeah, you did that.
We had one student who reached out to us because they
That
had
was
an issue.
me.
Oh, okay, that was you. So good. So that's it. So does anyone have any other problems regarding the topics in first stage, small topics which we have not studied as of yet? So what I'm going to do is you guys can take your time, okay, go through the topics. If you guys need help to make any videos with any small things which we have not discussed yet or which we will discuss in the future, considering they're just a bit small so that we can cover it in like an hour or so, please send us an email with those topics. We will try our best to make the videos out of those topics so that you guys can answer the questions in UWorld perfectly. Okay, we will be more
Maybe
than
vitamin D.
Vitamins, yeah, I was just gonna say that.
Vitamin D, like especially with bone mineralization reabsorption.
Okay, vitamin D. Okay, so we'll
My
make
friend wrote the STEP exam right now, and they had like 12 questions on vitamins alone. So
vitamins.
yeah.
Fortunately, the best news for vitamins are, since vitamins are not taken seriously in bachelor's, but vitamins are taken very seriously in USMLE, what we would be doing is for vitamins, not only are we going to study first aid, we are also going to use the picture mnemonics from physio. So we are saving the physio for all those picture mnemonics of vitamins. If you guys can see my screen over here, okay, let me show you how the vitamin section of physio looks like. Okay, it's actually kind of amazing. I mean, they have everything over there.
So would you say physio is better than sketchy? Like,
I personally have never used sketchy in my life. I find it, I found physio very helpful in the sense that physio has picture mnemonics for picture mnemonics, and physio also has explanations. So as you can see over here that they have all these vitamins. Okay, wait 1 second. Okay, so you see they have all these pictures for the vitamins. Can you guys see my screen?
Yes.
Okay, so you can see that they have different types of pictures for thiamine, riboflavin, niacin, pantothenic acid, pyridoxine, biotin. And the good news is we will be using these pictures ourselves with this picture mnemonic with our subscription so that every one of the students can tap into this and also use the Nimbus for recording the videos and everything that they need. Also use the subscription. So no need to worry about vitamins. We will have this covered. Okay?
When you click it, it basically is a video. Is that what it is, or it's just a picture?
For students who have not subscribed to physio, it's just a video. But since we will subscribe to them, you can access the videos as well as you can also access the picture mnemonics and the questions associated with the vitamins. Okay. Okay. With that being, we don't have a lot of time to. It's 1:49. We're actually kind of moving backwards. Some last question before we move to the next section of our lecture is if you have a child, okay, 1 second, if you have a child with hemorrhage, let's show you hemorrhage within first 5 days of birth. What is the source of the
listeria?
No. I'm asking about the source of the bleeding. Source from which?
Germinal matrix.
Germinal.
Ah, yeah.
Okay, germinal matrix. Okay, with that being said, can we end the URL notes section? First of all, let me thank
Yes.
you. Thank
Please.
you all so much for. Did I hear someone say please?
Yes. For
Okay.
Becker, it is out frame or non-frame, or it is same.
For Becker's, it's non-frame. For Dushin, it's in-frame.
Yes, because you write out frame.
Out frame mean out. Okay, so out frame, out of frame deletion or non-frame deletion.
No frame.
The same thing. Okay.
Also, can you post the URL notes from Pompe disease onwards because they haven't been updated?
Really?
Yeah, I just checked because I see at the bottom of today's notes you wrote like iliac nodes and stuff. That's not there.
That's. I suppose that should have been there.
But
Okay.
if you control find Pompe, like
From
that's
Pompe
the
disease.
last part.
Okay. So that's what we're going to do. We're going to look into this.
Right
And
there.
what we're going to do is we're also just going to give this whole thing in the URL notes and the files portion or in the document or in the media portion. So you guys can tap into this whole notes by itself. So what this
One
will
more
allow,
thing. Oh,
this will allow you to do is this will allow you to print those notes with the help of a printer, and you can just read them when you get the chance. We have made a lot of notes in the past 1 month.
Yeah, 18 pages.
One more thing, Dr. Haidari, I'm sorry. I look on the Facebook group because you said there will be the first a PDF version, but I couldn't find it. I don't know, like I threw all the posts, but I don't know why is it not there. I'm not sure. Maybe I did a mistake. I'm not sure.
Okay, no problem. If you can't find it, we will send everyone the first aid request and give you out and just give everyone the access. Okay, so
Thank you.
you will get it, no problem. That's 100% guaranteed. Okay, with that being said, the URL notes sections are done. We already have students who have left our lectures, okay, because it's been so long. So if anyone, for all the students who are here still looking at the lectures, thank you so much for being with us. Okay, we have had quite a discussion today. We have had some discussion regarding some high-yield URL notes. Do you guys want to continue the notes, I mean, the lecture a bit longer and get done with the URL questions, or do you want to stop the lecture over here right now?
Questions, please.
We can do the questions.
Okay, let's do the questions. And for the students who need to leave, we understand. Okay, it's been more than 2. And just want to thank you all for staying with us for so long. And for those students who are willing to leave, please send us an email if you have any questions or concerns regarding our lectures. And please do not forget to complete your transaction for next week, Monday. And if you guys need extension, please let me know. We'd be more than happy to provide you with extensions. Okay. With that being said, just give me 2 minutes so that I can prepare the questions regarding nephrology. Okay. Okay, so we are ready to do our 5 questions, regular UWorld questions, offline UWorld questions regarding nephrology. That's what we're going to do. And having said that, let's begin. We don't want to waste any more time. Please feel free to unmute yourselves and give me the proper answers only when you are asked. Okay. And let's begin. This is the first question. Can everyone hear my voice? Is the voice clear? Can you guys see my screen?
Yes.
Mm-hmm.
Okay. Okay, let's begin. Okay. Shorter question. First thing which we do, read the last line. The majority of the total amount of water filtered by this individual's glomerulus is reabsorbed in which of the following portions of the nephron? A 54-year-old missionary traveling along in a remote region of Southern Asia becomes lost. After several days, he arrives at a small village. However, he hasn't gone 24 hours without food. Do you guys realize you guys can answer this question without even reading the first portion? Okay. So which one of the following portion is the most important for absorbing the most amount of water?
Loop of Henley.
Okay. So how many students do we have for C?
Me too.
Okay. Why is C the right answer?
Because that's where it concentrates the urine, right? It's
the
impermeable to
concentration
sodium,
there reached
but
very high.
permeable to water.
Do we have any other student with any different types of answers?
Collecting ducts.
Maybe proximal tubule.
First of all, which portion of the nephron is important for absorbing the most amount of sodium?
Proximal.
Proximal tubule.
Proximal
Does sodium go alone or does sodium pull
DCT
water?
also, right?
No. Do you guys remember that 60% of sodium is absorbed in proximal convoluted tubule? Yes or no?
Yes.
Yes.
Sodium is absorbed 60% in the proximal convoluted tubule. Does sodium move by itself or does it take a
With
lot?
water.
Water, yeah.
With water.
So if the maximum amount of solute is being observed in the proximal convoluted tubule, why is it not possible for the water to be also be the maximum amount to be absorbed in this segment? Is that a possibility?
Because sodium will be absorbed, so it's more
The
focused
answer
on
is E.
So the answer is
E.
E.
Have you guys understood why the answer is not the rest?
Yes.
Okay, everyone clear?
No, I'm not clear.
Yes.
So E, right? E is the right
Not
answer.
clear? Okay.
I'm not clear. I'm not clear.
Okay, if you're not clear, then I'd be more than happy to make you understand once again. No problem. Okay. So what's happening is, let's say that you have the basement membrane, okay, and then you have the glomerulus, then you have the proximal convoluted tubule, loop of Henle, distal convoluted tubule, collecting duct. The proximal convoluted tubule has the most amount of sodium reabsorbing channels. Now the thing is, sodium does not move by itself. Sodium, when it moves inside, sodium carries water along by itself. Proximal convoluted tubule has 60% of the sodium being absorbed from the proximal convoluted tubule. So if the 60% of the sodium is absorbed in the proximal convoluted tubule, the most amount of water is also being reabsorbed in the proximal convoluted tubule. Okay. So with that being said, does that clear your confusion and make you understand why the answer is E?
Yes.
Yes. Can you maybe say in the other parts which are what is absorbed with the other parts, or like to take it too much time, or will we discuss it in the next week?
And next week will be page 585.
Exactly. We will focus on this more next week. We have not discussed this as of yet. So that's that. Another thing which I wanted to tell you guys was the answer percentage of proximal convoluted tubule is an astonishingly low percentage of 28% of students who said proximal convoluted tubule. I mean, proximal tubule. 39% said medullary collecting duct, and 15% said loop of Henle. The rest were very low. Okay, so that's that. So this was a very difficult question. That's that. So just for these type of questions, try to realize which part is being absorbed more, and that will be it. Okay, 1 second. Okay, this is a big one. Okay, very big question. Okay, what we're going to do is we're going to read the question and see what's going on over here. So the question is, which of the following is the most likely cause of her condition? So this patient should have a condition. A 40-year-old woman comes to the office with a 6-month history of involuntary passage of few drops of urine when sneezing or coughing. What type of incontinence is this?
Urge.
Stress. Stress.
How is
Stress
it?
incontinence.
No, stress, yeah.
Stress incontinence. Very good. This is stress incontinence. She has recently, so if you have figured out that she has stress incontinence, okay, do you have to read the rest of the things? Yes or no?
No.
Okay, you do not have to read the rest of the things because all they
Just
want
go
to
through maybe.
yes, you can, but the thing is, they're basically asking you what is the cause of her condition. Her condition is
Yeah.
stress. So which one of this is the right answer?
F.
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 Last
F.
one.
Which one?
Urethral
Last one.
sphincter dysfunction.
Are we all on the same page with this one?
Yes.
Okay. So
Yes, doctor, but why we didn't
Why?
read
why
the
why what?
we didn't continue to read? Why?
Okay, good question. Good question. So we didn't continue to read. Why is that a good question? And the answer is that what your exam will do is they will give you a lot of information over here which are not important at all. I'm going to tell you why this is not important. That is why we ask you to read the last line of the question, because when you read the last line of the question, having kept in mind that you only get 90 seconds to answer each question perfectly. So you need to know which questions are required for you to read, especially questions regarding genetics, biochemistry, neurology. They have little snippets of clues over here. But for questions like this, which is a direct question, the direct question is, which of the following is the most likely cause of her condition? The patient is a woman and she has a condition, and they are asking about the pathology over here. Okay. So the thing is, first of all, if you can identify her condition from the first line, that is the 48-year-old woman comes with a drop of urine when sneezing or coughing, you immediately identify her condition. So you are linking this to this, meaning that you are identifying that she has stress incontinence. And even if you read the next lines, you will realize that there's nothing important over here, which will allow you to answer or not answer this correctly or incorrectly. So that's the reason. If you want, you are more than happy. You should actually read the whole question, but if you want to save time for questions which you are sure like this, you can really not read them. Are we clear, Dr. Mohammed?
Yes, thank you.
Okay, perfect.
Also, I wanted to add one thing. So, like when I was doing the U-World question for something very similar to stress incontinence, they took the question one step further, where they were treating the person now with the Kegel exercises, and then they asked like, what's the target of the exercise? Like what muscle?
Target muscle. Yeah.
So now it's like levator,
and
ani muscle.
okay. So let me also add this to this discussion. If we would not ask this question in the future. First of all, the question asked and the information provided by Dr. Tain is very helpful because you will receive this question. That is, how do you treat a patient with stress incontinence? What is your answer, everyone?
The Kegel
Size muscle.
Kegel exercises, muscle. Yeah. And UWorld has a tendency of repeating questions, and they will repeat the question again and again, and they will ask you, which pelvic muscle does the Kegel exercise strengthen?
Levator ani.
Please remember this association, because Dr. Tain is correct. They will keep on asking you this over and over again. Okay, good. So far so good. Next one is this one. Okay, how about for this one, I do not read this. I just give you guys the time. It's 2:05. Can I get my answers by 2:06? Okay, read the whole thing. Only when you're ready, say you're ready and tell me the answer.
Ready.
Oh, okay, one student is ready.
Ready.
Okay. Okay, very easy question. So can I get the answers, please?
D. Respiratory distress.
Respiratory distress.
D, yeah.
Okay, why?
Because Potter
sequence will happen.
consequence.
Okay.
Oligohydramnios.
Yeah,
That-
olive
that is
hydramnios.
very good.
So
There's
polio.
one thing I want to talk about though. The ultrasound reveals a male fetus with
It's
bilateral.
autosomal recessive polycystic kidney.
Perfect. Thank you so much. Who do I have the pleasure of talking to over here?
Dr. MS.
Okay, Dr. MS. Thank you so much for letting me know that the disease is autosomal recessive polycystic kidney disease. Okay, perfect. Next one. Okay. Next question. And we are going to do the same thing that we did the last time. I'll give you guys 1 minute. Read the question, and only when you're ready, tell me you're ready.
You're hiding the upper part, doctor.
Oh, I'm sorry. We have discussed about this today. Very, very important and a very complicated question, but we have discussed about this today. That's the best clue I can give you regarding this question.
Ready.
Ready, very good. Anyone else?
Ready.
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 Very good. Can I hear one by one? Number one who said ready, I suppose it was Dr. Mohammed. Was it Dr. Mohammed? Please tell me your answer.
Yeah, I'm saying C.
Okay. Does anyone else have any other different answer than C?
Yes.
No.
Okay, okay, what's
I
the
think
difference?
it's C.
D.
Okay, okay. How can you surfactant deficiency?
But that's in prematures, no?
Okay, right.
This is full term.
It's a 1 hour old boy. Okay,
Hmm?
39 weeks of gestation. Do you really think that you can find surfactant deficiency in the autopsy? First of all, what is
Yes.
the most likely cause of this patient? What's happening over here? This patient has Porter syndrome. Okay, this patient has
Porter syndrome.
I would
now
go with B, duodenal atresia.
You said
duodenal
cause of death was pulmonary hypoplasia.
duodenal atresia will cause polyhydramnios. So
Yeah.
not the right
Okay,
answer.
polyhydramnios. Sorry.
So yeah, correct answer is actually C. Okay.
C. Yeah. No
Answer
urine.
D, okay, the percentage of students who said C was 41%. The percentage of students who said D was 32%. Because although surfactant deficiency can cause hypoxia, okay, it is commonly associated with prematurity and would not cause any facial or lower limb deformities.
Yes.
Okay, they will not cause any facial or lower limb deformity. The only reason why the facial and lower limb deformities are occurring over here is because due to the absence of fluid in the amniotic cavity due to the presence of the most important cause of young male infant bladder outlet obstruction, that is posterior urethral valves. Are we clear on this?
Yes.
Yep.
Okay.
Which is also associated with Porter syndrome, right? Like the.
This is Porter syndrome.
Right. Okay. Right.
Okay.
Yeah, the first thing that I have got in my mind, Porter syndrome.
Right. So it was a correct thing.
Flattened nose was there.
Right. Flat nose. Okay. Last question. I will read this with you guys. Okay. Last question of the week. Which of the following adult derivatives will fail to develop? We talked about this. Researchers working at a national foundation that occur during embryonic, okay, blah, blah, blah. There is research focuses on the molecular mechanism forming the, okay, not important. The inductive signal changes between the, okay, specific, now this is important. The signals exchange between the metanephric diverticulum and metanephric mesoderm that drive the differentiation into the tissue form.
B.
Okay, but toxic and solvent.
B.
Okay.
Distal convoluted tubules.
Okay. So which one is not being developed, the uteric bud or the metanephric mesoderm?
The metanephric mesoderm.
Which one of the following segments over here is the only one that develops from metanephric mesoderm?
The distal convoluted tubule.
So, which is the correct answer? B is the correct answer. Okay, everything else will develop. Okay, good, very good. Okay, so with that being said, we are ending our very long lecture for today. First of all, let me thank you so much for being with us. Okay, I'm going to mute you all and thank you for participating. Okay, I'm sorry. Who was the one with the question? Well, what is your question? You are at liberty to unmute and ask me the question. No problem.
It was me, Dr. Mohammed Abriash.
Yes,
Doctor, you said it was the only answer there about the metanephric. You said that it was the collecting duct, but actually they were written cyclases also.
They were?
Salicysis, sorry. Salicysis were written also.
If a toxic insult occurs during fetal development and selectively inhibit the renal structures formed by the metanephric mesoderm. Over here, distal convoluted tubule is the only structure formed by the metanephric mesoderm. All the other structures are developed from the ureteric bud. So as a result, which of the following adult derivatives will fail to develop? Distal convoluted tubule will fail to develop. That's the reason. Is there still a confusion? Do you remember that I told you that metanephric mesoderm is responsible for giving rise to all structures of the kidney from PCT to DCT?
Yes.
And the rest are developed from the ureteric bud. So if the ureteric bud is okay, but the metanephric mesoderm is not okay, so the only structure that will not have problem with is your DCT. So DCT will not develop. So that's why DCT is the correct answer.
Okay, thank you.
Okay,
Yes,
you
thank you.
are absolutely welcome. Thank you so much for asking that question and getting your confusion cleared out. And to everyone who has said thank you, welcome, welcome, and hope you guys have a great weekend. Okay, I will send you the neurology assessment by this week. And to the students who has joined this week but has not received lecture 31 and 32, I will send you the lectures 31 and 32, and we will start our next week. From Monday. We will send you the transaction informations on PayPal. Please try to complete your transactions for Monday before Monday. If you fail to complete it before Monday, just send me an email saying that you need an extension and I will give you that extension. But if we fail to receive emails or fail to see completions of transactions by Monday, we will assume you do not want to continue with us and we will stop bothering you, and stop providing you with the Zoom URL. Okay. Okay, and we will also send the psychiatric lectures on Google Drive. Of course, we will, like neurology. And once again, thank you so much. Each and every one of you are absolutely brilliant students. You guys will do amazing. Okay, try to apply the knowledge which we gain during our lectures by doing UWorld questions. Okay, along with this, just wanted to wish everyone a very good weekend ahead. Okay, don't forget to have fun with your friends and family. Okay, and with that being said, I will take my leave for today. And let me know if you guys have any questions. Send me an email and I'll see you guys on Monday. Okay, bye-bye now.